Good afternoon, everybody. I welcome all of you for this academic events of Endometcon-3. Let us now start with the Ganesh Vandana.
Kurutvam kalyanam arogyam dhanasampadah Shubham kurutvam kalyanam arogyam dhanasampadah Shatru buddhi vinashaya Deepajyotirnamostute Deepajyotirnamostute Shubham kurutvam kalyanam arogyam dhanasampadah Shubham kurutvam kalyanam arogyam dhanasampadah.
Good afternoon. We welcome you to the academic competition preceding the FOGSI 3rd International Conference on Endometriosis, Endometcon-3, being held on 9th and 10th December 2020, organized by FOGSI. On behalf of Jacksonpal Pharmaceuticals Limited, pioneers in Dynagest 2mg tablet formulation as brand Endoreg for endometriosis-associated pelvic pain, Cyclorex CR10, Northestrone 10 mg control release tablets, and injection Gonadoreg containing leuprolide acetate 3.75 mg. I am Dr. Vipin Tyagi along with my teammates, Dr. Deepika Chavda, Mr. Arvind Singh, and Mr. Amit Saxena. We are thankful to FOGSI organizing committee members for providing us the opportunity to host the academic competition of the Endometcon-3 today. Thank you, Dr. Alpesh Gandhi, President FOGSI, Dr. Jaydeep Tank, Secretary General FOGSI, Dr. T. Ramani Devi, National Vice President FOGSI, Dr. Kanthi Bansal, past Chairperson Endometriosis Committee, Dr. Asha R. Rao, Chairperson Endometriosis Committee, and Dr. Kundan Ingale, Chairperson Infertility Committee. All the best for the competition to all the participants, and a warm welcome to all attendees who are present with us today to boost the morale of the participants and witness this unique academic competition. Please note, this webinar is brought to you as knowledge sharing initiative by Jacksonpal Medical Services, and this session is streaming on Facebook Live. The recording will remain on Jacksonpal's YouTube channel for reference and promotion. I will now request Dr. T. Ramani Devi ma'am to kindly initiate the session.
Good afternoon, everybody. I welcome our FOGSI President, Dr. Alpesh Kanthi, who has been always supporting us. When I asked for this exclusive conference on Endometcon, he immediately accepted. Then he said we can go ahead. So under the able guidance of our President, Dr. Jaydeep Tank, the Secretary General, past Chairperson of Dr. Kanthi, Chairperson of Endometriosis Committee of FOGSI, Dr. Kanthi Panchal, and Committee Chair currently Dr. Asha Rao and Kundan Ingale, and all the team members. We all joined together and we thought we will have a pre-conference academic session. So with that, we thought of having a quiz program for the postgraduates, essay competition for the postgraduates. Again, for the consultants, we thought of having poster presentation, oral presentation, and then videos. So I immediately, the executive committee members of this Endometcon-3, Dr. Sebanti, Dr. TV Chitra, Dr. Chitra Ramesh, Neharika, Venugopal, Oby Nagar, Mahapatra sir, Pradip Kumar sir, Dr. Subash Mallya, Dr. Priyankur, Dr. Vidyadopi, Dr. Neelam Mishra, Dr. Mala Raj, Dr. Vidya Bhatt, Ashish Kale, Krishna Kumar sir, and Parishit Tank and Pratik Tambe. All of them, they immediately agreed and they shared the work by doing their own, they're forming an own organizing team, and they have done a wonderful work. And today, the first of it, the program will be the quiz competition for the postgraduates. Before that, I request our president, visionary president, Dr. Alpesh Gandhi, to say a few words of blessings to us this day. Thank you.
Thank you, Dr. Ramani Devi. I welcome you all to this International Conference Endometricon 3 Today we have academic competitions. We all know that endometriosis is an elusive challenge, and the management of endometriosis has evolved greatly over the years. This year we have started one unique feature with all our programs. We are organizing different competitions, and we have seen our members are participating with great enthusiasm. There is always very active participation from our members, and we have observed that they are multi-talented. I congratulate Dr. Ramani Devi, Vice President FOGSI, for this wonderful, very informative, very useful international conference Endometricon-3, and I also congratulate Dr. Kanthi Bansal, Scientific Chairperson for the conference, for the hard work and bringing us a very, very interesting scientific program with many international and national faculties in the field. We are also thankful to all the coordinators. I am not repeating the names. Dr. Ramani Devi has already mentioned the names of all the competitions: quiz competition for postgraduates, essay competition for postgraduates, and paper and poster presentation for consultants and video presentation for consultants. We are thankful to all the coordinators for their valuable time, their expertise, and their hard work. And I'm sure all our postgraduate students and all our consultants will definitely enjoy these academic competitions. With this, once again, I wish grand success to this academic competition. I wish happy learning through this competition. I wish safety to all of you. Thank you very much for participating, and thank you very much for inviting me for your patient hearing. Thank you.
Thank you, sir, for your kind words.
And as the chairperson of Endometriosis Committee, I'm so grateful to dear Sir Dr. Alpesh Gandhi for having given us this inspiring address. And I also thank Dr. Ramani Devi and congratulate her for having organized such a wonderful conference over such a short period. And also to Dr. Kanthi Bansal for supporting us. So thank you very much for this gesture, Dr. Ramani and the organizers.
Congratulations, Dr. Asha.
Thank you. Thank you so much.
Congratulations, Dr. Kundan. And it is good to see all our committees are so active in this difficult time of COVID-19. You all are doing wonderful work, and please continue the great work. Thank you.
Thank you, Dr. Alpesh. It was such a pleasure to be working with you under your valuable leadership. And Dr. Ramani Devi also has great leadership qualities. And with Asha, Kundan, Priyankur, all together, we were successful in bringing out this very unique and magnanimous conference, and very nice to see you. Thank you. Next, Deepika, I think we can start with the program, academic program. You please share the CV for Dr. Sebanti, Dr. Chitra, and Dr. Chitra Ramesh. Dr. Sebanti Goswami is current chairperson of Quiz Committee of FOGSI, and she is a senior consultant gynecologist from Kolkata, former associate professor, Medical College of Kolkata, and she has numerous publications in national and international journals, and her special interest is vaginal surgery and cosmetic gynecology. Next chairperson is Dr. T.V. Chitra, who is from Coimbatore. She is the professor and head of the unit of PSG, Medical College, Coimbatore, and president of Coimbatore OBGYN Society. She is affiliated to Ayuga and ISUOG, and her special interests are urogynecology, high-risk pregnancy, conducting PG program, CMARC, which was recently conducted, and it was very successful. And she had undergone training in urogynecology in KK Hospital, Singapore, KGH, Chennai, and IFSCP accredited colposcopist, and she is usually, she has been admired by her students, and she is a very fond teacher for all her postgraduate teachers. Next, Dr. Chitra Ramesh, a young gynecologist from JIPMER, fellowship in minimal access surgery, fellowship in reproductive medicine, fellowship in advanced laparoscopy, infertility and ultrasonography, with a good teaching experience of around 14 years for undergraduates and 12 years for postgraduates, got Best Paper Award for many papers published in national and international conferences. Dr. Asha Rao Award for Best Poster Presentation in ISA 2017. Srimati Shanta Hanji Gold Medal Award in Best Paper. First Best Paper Award in International Conference AVOFOG. Then published paper in many reputed national and international journals, and she's a member of so many associations and secretary of Pondicherry Society of OBGYN and treasurer for Indian Fertility Society. See, initially, some years back, probably 1 year back, Chitra and myself, we were thinking of organizing this Endometcon physically,
Yeah.
but because
Yes,
of
ma'am.
this unfortunate COVID, I won't say unfortunate, because it has given opportunity for many of us. See, thousands of people have the opportunity of viewing this Endometcon
Yes,
because
ma'am.
it's a e-conference.
Yeah.
So over to Dr. Chitras and Dr. Sebanti.
Good afternoon to everybody. I thank the President, Dr. Alpesh Kanthi, as well as the Vice President, no, don't go over there, Vice President, Dr. Ramani Devi, to give us this opportunity of having this quiz on the web. At the starting of the pandemic, we were wondering how are we going to have quiz on the web, because that is something which requires a very much physical presence of the people, but we have been doing it now, and the apps are also helping us to do. Today, the entire quiz will be on endometriosis. We have 3 quiz masters. Along with me, I have 2 quiz masters. We have Dr. Devi Chitra and Dr. Chitra Ramesh. They have already been introduced by the organizers. Can we move on to the next slide, please? Yeah. So now many of the participants are wondering how to play the game. Just a brush up of how to play the game, because Kahoot is new to many. Download the Kahoot app in your mobile. All these instructions have already been sent to all the registered participants in the mail. So they must have downloaded the Kahoot app in their mobile. Deepika, please mute yourself. Keep 2 devices with you. Keep the Kahoot app. It's always customary to keep the Kahoot app on the mobile in your hand and view the questions which will be asked by us on the Zoom screen. So laptop for a Zoom and Kahoot in the mobile. Open the Kahoot app. You will see the game pin will be displayed by us on the screen. Enter the game pin, which is displayed by us. Then you enter the nickname. Be sure that you are registered. Then only you must have received the nickname in your mail. So it is like Endo1011 or something like that. Please enter that in your Kahoot app. Then you will be pushed up to the podium. The one who gives the fastest click becomes the winner of that particular question, because as this is a app-based game, obviously many of you will be giving the correct answers. This is not a physical quiz. So even if 100 people give the correct answer, the one who is giving the fastest one will be declared as the winner. Please keep your PG ID card ready. This is a very vital thing, because at the end of the quiz, because we do not have all of you physically in front of us, we will be promoting you to the faculty platform, and then you will be visible in front of us in the Zoom. Then you will be able to show us the quiz, the PG ID card, and then only we can confirm that you are the same person. Then only you will be considered for the prizes. Beware that if you cannot show us the ID card at the end of the quiz in the Zoom platform, then you will be disqualified, even if you have won the quiz, and the person with the next rank will come up as in your place. May I have the next screen? There will be 3 rounds in totality, 10 questions in each round, 30 seconds to answer each of the questions. First round will be MCQs, which will be taken by Dr. Devi Chitra. The second round will be MCQs again, and that will be taken by Dr. Chitra Ramesh. And the third round is a collection of true and false question answers, which will be taken by me. And like any other quiz in any part of the world, it is a Quizmasters decision, which is final. So with that, wish you all the very best. Please try to follow the rules of the Kahoot game, and let us all enjoy the game. So with this, I give hand over to Dr. Chitra Bhatt, or TV Chitra Madam, to start conducting the first round. And can we have the help from the technical persons, please?
A very good afternoon. At the outset, let me thank Ramani Madam for having given me this opportunity, and Dr. Sebanti for having coordinated with us. And thank you both of all and the entire organizers for this opportunity. In fact, I was wanting to do this for a long time, but somehow because this is virtual, we could not do it earlier. Now, straight away coming to think, we have all the players. I'm sure you're well versed with all the rules. So can we start now? Yes.
They are
Can we go on to the? Yes.
They are registering.
Okay.
Yeah, we are
Okay.
getting.
Now that okay.
Ma'am, please hold. They are all.
Okay. Once you tell us you're ready, you tell us.
Yeah. They are putting in the gate pin and coming.
Okay, fine. Students, wishing you all the best. I'll only read out this term. The choices will be there. We have to mark the best response. So get ready. Once we're giving the signal, we'll start.
You start, Dr. Chitra and Sebanti, you start.
Yeah, Dr. Chitra,
Yes,
you start.
Okay. Can I have the first slide, please? Now we're having the first question. Endometriotic lesion pathologically overexpresses all except. We'll have 30 seconds. You can see the timer there. Okay. Now the answer is 17 alpha hydroxy dehydrogenase because it's basically a estrogen dependent area. Next question. Second question. The most common extrapelvic site of endometriosis. This is a very easy question. So the answer is GIT. Colon is the most common extrapelvic site of endometriosis. Next. Lifetime risk of developing endometriosis in a woman with a first affected first degree relative is, what is the percentage? The answer is 10%. Next question. Fourth question. Cross mutation in endometriosis associated ovarian cancer is seen in what percentage? 5, 10, 25, 15? So the answer is 5%. Next. Best diagnostic modality for deep invasive endometriosis is this also very easy. MRI is the answer. Good. Many have answered it correct. Next question. Who identified endometriosis? Again, a very easy question. Good. Thomas Cullen is the right answer. Okay. Yes. Next question. What is the difference between NCN and revised ASRM criteria? What does it include or exclude? Yes, it includes DIE, correct? Quite a few have answered it right. Yes. Next question. Next question. 8th question. EAOC is predominantly what type? Very good. Many have answered it right. Clear the customers, the answer, yes. Okay, good. Next. The following is a risk factor for endometriosis. Very simple question. Yes, pinpoint cervical loss. Okay. Last question. EFI predicts endometriosis fertility index. What does it predict? Okay, so it's non-IVF pregnancy rate. Very good. So people are going on changing. Now that comes to the end of the first round. We'll move on to the second round. Dr. Chitra will take over from us.
I welcome Dr. Chitra Ramesh to take the second round, which is also going to be a MCQ round. Over to you, Dr. Chitra Ramesh.
For that, I'd like to thank Ramani madam for giving me opportunity to be a part of this coordination for Quizmasters. Thank you so much, ma'am. So next question, please. Which theory best describes why the most common sites of endometriosis are the ovaries and posterior cul-de-sac? The answer is
Sampson-Spill theory.
it shows that retrograde menstruation. Yeah. Next question, please. Which theory would best explain endometriosis in an adolescent before the onset of menstruation? Yes, this answer is mystery, that is a metaplasia of coelomic epithelium, which causes the cells in the peritoneum. Next question, please. What is the incidence of recurrence of endometriosis? It's a recurrence. Yeah, the answer is 5 to 15%. Next, please. Which is a contrastive design which is showing a promising effect in recurrent endometriosis? The answer is the LNG-IUS. Yes. Next question, please. What depth of infiltration is used to define deep infiltrating endometriosis? The answer is more than 5 millimeter depth into the peritoneum. Next, please. What is uterine sliding stent, which is a diagnostic of? While doing ultrasound. It is diagnostic of rectovaginal endometriosis. Next, please. The first histological description of utopic endometrial implants was credited to. I think others can unmute. Sorry, mute, please, because your answers have been heard by others. It is von Rokitansky. Next, please. The evil triplets of chronic pelvic pain are. It is interstitial cystitis, levator neuralgia, and endometriosis combination forms evil triplets. Next, please. The mechanism of action of non-hormonal treatment of endometriosis by statins include all except. The answer is vasculogenesis. It acts by anti-vasculogenesis action. Next, please. Dopamine agonists such as cabergoline and quinocolide in endometriosis acts by all except. The answer is it deactivates vascular endothelial growth factor, causing its dephosphorylation. Yeah. I think I'm going to end with my session. Thank you, ma'am.
Chitra Ramesh. Now we come to the last round, which is also a round of 10 questions, and all of these questions are true or false. So you need to pick either true or false block in your Kahoot app. And here we go with the first question, please. The ovarian tumor marker other than CA125 seem to be elevated in endometriosis is CA19-9. True or false?
Ma'am, next question.
Yeah, but you don't show this the maximum number and all percentage in here as like the other questions.
Ma'am, it was shown.
Okay, the next question. July is the month of endometriosis awareness. True or false? Yeah, it is false because March is the awareness month of endometriosis. Next question. The AFS code is 36 if POD is totally obliterated. True or false? The correct answer is false because when POD is totally obliterated, the score is 40. Next question. Blue color ribbon is used in endometriosis awareness. True or false? Obviously, this answer is false, and this answer is almost in the ribbons everywhere because the color of the ribbon is yellow. How could 13 mark it as true? I cannot understand. Next question. The hematological cancer that is found to be slightly more in women with endometriosis is chronic myeloid leukemia. True or false? The correct answer is false because it is not CML, but it is the non-Hodgkin lymphoma, which has been found to be more in women with endometriosis. Next question, please. The plasma half-life of Dynagist is 9 to 11 hours. Is it true or is it false? The correct answer is true. Next question. Dynagist has androgenic activity. True or false? The correct answer is false because that is a progesterone which has no androgenic activity because of the placement of the cymethyl group instead of the ethynyl group at the 17 alpha position. Next question. Negative histology does not exclude endometriosis in the diagnosis. True or false? The correct answer is actually true because if you have a positive diagnosis, positive histology, then it diagnoses endometriosis. But if it is negative, you cannot rule out endometriosis. The ninth question. Suppression of ovarian function to improve fertility is not indicated in infertile women with endometriosis. True or false? The correct answer is true because if the woman is having infertility as well as endometriosis, there is no point in suppressing the ovulation. Rather, we should initiate it and get her pregnant as early as possible. Last question. Dynagist is a third generation progestin. True or false? The correct answer is false because Dynagist is a fourth generation progestin. Now we are over with the quiz. Let's see what app tells us who wins, who comes first, who comes second, who comes third. Okay, so the system tells us that Endo 1061 is the winner, right? 1061 is the first scorer. So
Yes.
let us see who is 1061. 1061 is Dr. Shudha Shanti. Dr. Shudha Shanti, requesting you to raise your hand on the Zoom so that we can see you and confirm yourself with your ID card. Dr. Shudha Shanti 1061, please raise your hand if you are there. Raised. There is a raised hand option. Yes, ma'am. She has written in the chat. Yes, ma'am.
Ma'am, I've promoted her. I've promoted her to panelist.
Okay, Sudha Santi, could you please show me your iCard? Make yourself visible.
Your
Please.
video will be working now.
Your video will be working now. You can be made visible. Please put your video on. Dr. Sudha Santi. I can see her window. Yes. Please show us your, please zoom it out. Please zoom it out and show this is your voter ID card. Please unmute yourself.
You can speak.
You can speak.
I'm doing post-graduation in KMCH, DNB, ma'am.
Okay. So
Yes.
taken.
Clear, ma'am.
Coimbatore. Okay. Dr. Sudha Santi is taken as the first winner. Who was the winner? A big clap to Dr. Sudha Santi as the first. The second person in the podium. What is the endo ID, Deepika? So the second person is 1026, right? 1026 is Dr. Janani S. Dr. Janani S, raise your hand in the chat or write something in the chat so we can promote you. Dr. Janani, can we have a glimpse of yourself?
Actually, I'm getting only Dr. Vaishali Verma or Bhagya Lakshmi. Who is Dr. Janani? I am not sure.
Dr. Janani S is 1026. The code was 1026, right?
Bhagya Lakshmi Sabhavat, is that the one?
No, what was the code? That was 1026.
Right.
1026 in your list is Dr. Janani S.
Yes.
From Chennai.
Yes, but the person who has raised their hands.
Somebody else is playing for Dr. Janani.
No, I'm going to lower all hands. Please raise your hand, Dr. Janani. Dr. Janani, yes, we need to see your card. So please raise your hand.
First, and then we need to see your card.
That is Bhagya Lakshmi. I'm going to promote Dr. Bhagya Lakshmi.
Let's see who comes out of that window.
Right. I've promoted. Now your video and audio will work. Dr. Bhagya Lakshmi Sabhavat. Are you Dr. Janani S?
I'm Dr. Janani. I'm using Bhagya Lakshmi's laptop. So the name is Bhagya Lakshmi. I'm sorry.
Okay. Please zoom your ID in front of the thing. Which institution do you belong to?
Ma'am, I'm from Madras Medical Mission.
From Chennai?
Yes, ma'am.
Okay. So we
Just zoom it a little more.
Zoom it a little more. The Quizmasters demanded to be zoomed a little more. Okay. So Dr. Janani becomes the second person. What is the code number of the third? What is the code number of the third?
1024.
1024 is Sonu Grewal from Chennai again. Sonu Grewal, please raise your hand. Sonu Grewal, please raise your hand.
Yes, I am promoting her to the panelist. Now you will be visible.
Now you can talk now. Please let us have a glimpse of yourself and let us have a glimpse of your iPad so that we can promote you to the podium. From which institution are you?
Madras Medical Mission Hospital, ma'am.
Okay, please show us your card.
Little bit nearer.
Nearer, little bit nearer.
Little more. Okay.
Okay. So our job is done. The first in the Dr. Sudha Santi from Coimbatore. The second is Dr. Janani from Chennai. And the third is Dr. Sonu Grewal from Chennai. Give them all a very big hand. Thank you very much. Very good.
To share one thing, Dr. Sudha Shanti was working with me some years back, some 2 years back.
Oh, that's
she joined her Dip and B. She was working with me. So
no wonder she's the winner.
No wonder she's got first, ma'am.
Ramani is a very good teacher.
Yes.
Congratulations, Ramani.
Thank you.
I thank all my congratulations. Thank you, Deepika, for being with us, for your endless support. And special thanks to Dr. Rajesh, who is with us today also, and who led us to this Kahoot app, and we could do it in this platform. And once more, thank you, Dr. Ramani, madam, for your constant inspiration and support. Thank you all. Bye.
I think it was excellent work by all the three Quizmasters Dr. Sebanti, Dr. Chitra and Chitra Ramesh, hats off to you. I think you
I
have
really enjoyed
done
it,
a
ma'am.
wonderful job. See, my personal request is you send me the questions to me so that I will put it in the e-Sovner so that everybody can be benefited.
I'll mail it today evening only, madam.
Okay.
Congratulations,
Mail
Sebanti.
it in the evening so that by night we can add it to our.
I'll just now maybe.
Okay, okay.
I thank the quiz masters, Sebanti, Chitra and Chitra, and also congratulate them for having conducted it in a very interesting way.
Thank you, ma'am. Thank you, ma'am. Thank
And
you.
dot on time, ma'am. Dot on time.
Yeah.
We are 3 minutes to go even. It's 13:57.
Sebanti, it has been a very good conduction.
Thank you,
We
thank you.
must
Sir.
appreciate.
Shall we now move on to the next program?
Good evening, everyone. It was such a wonderful quiz program, and I congratulate all the winners. I expect that all the others should continue to participate in quiz and you'll win some or the other time. It was so nice, nicely prepared and executed. I really enjoyed every second of this quiz program. So now we move on to the essay competition. And for this, I would like to introduce Dr. Neharika Malhotra. What can I say about this nice little girl? She's grown in front of us. A very vivacious, energetic, and intelligent girl. And she is a consultant Rainbow at Rainbow IVF, chairperson FOGSI Young Talent Promotion Committee 2022. I think she's heading the right committee, and she's joint secretary FOGSI 2018. She's active member of so many organizations, and she's published a chapter in Jeffcoat Book of Gynec and Ian Donnell Book of Obstetrics and FOGSI Book of OBGYN 3rd edition. Endometrial receptivity and scoring for prediction of implantation and new markers. Ultrasound screening for fetal malformation has 3D made a difference, support 2010. Multiple articles also in various FOGSI Focus and newsletters and many more. Numerous awards and accolades. More than everything, what I really like about Neharika is she's very friendly, very warm-hearted and ever smiling. Welcome, Neharika.
She there?
Yeah, I would like to now introduce Dr. Venugopal. Yeah, I'm so happy to have such excellent coordinators in my essay competition. Dr. Venugopal, a very humble and thorough gentleman. He is a consultant ART specialist, ARMC IVF Center, Thrissur, Palakkad and Salim. Secretary General Kerala Federation of OBGY, Secretary Kerala Chapter IFS, Convener Andrology SIG IFS. Welcome, Dr. Venugopal. Very happy to have you with us.
Thank you. Thank you, madam.
Yeah. Now, I would like to introduce Dr. Oby Nagar. She is from Jaipur, senior professor and unit head, Department of OBGYN SMS Medical College, Jaipur, and she's a diploma in gynec endoscopy, K, Germany, FMAS, FICOG. She's held various posts in her career, and also she's a member to various, life member to various organizations, and is also having a lot of publications. I would say she's very soft-spoken, a very beautiful lady from Jaipur. Welcome, Dr. Oby Nagar. P. Das Mahapatra, yes.
Yeah.
I'm really fortunate, I must say, to be introducing Dr. P. Das Mahapatra, a thorough gentleman and a very good professor of endometriosis, and also he does superb endoscopic work, including research, etc. And he is a DGO, MD, FRCOG, FRCS, and from Edinburgh and Glasgow and London, he is having FRCOG. He is the Director of Spectrum Clinic and Endoscopy Research Institute, Kolkata, Examiner for MRCOT and FRCS, Edinburgh, Founder Secretary General of Endometriosis Society India, Founder President Medical Education and Research Society of India, and he is the life member International Society of Gynecological Endoscopy. Welcome, Doctor.
Yeah, good evening. I am pleased to introduce one of the judges for the essay competition, Dr. Pradip Kumar Mitra. Sir is he's a senior visiting consultant, OB-GYN and endoscopy from Kolkata. He is the director of the Dr. Prantosh Mitra Memorial Clinic from Calcutta. He is the founder and deputy secretary general of the Endometriosis Society of India. He is the organizing secretary of the International Conference of Endometriosis in 2015 and 2019, zonal coordinator of FOGSI, past president of Bengal ONG Society in the platinum year. He is a retired teacher, West Bengal Medical Education Service, past president, Calcutta Medical College, founder, PCO Health Club, Kolkata, and invited faculty to various conferences. Welcome, sir, and thank you for having been
essay competition is none other than Dr. Kanthi Panchal, who is the scientific chair for today's program, and also I should say she was one helping me throughout for organizing this Endometcon-3, and a good friend of mine. I'm happy to introduce her. She's a director of Safal Fertility Foundation of Ahmedabad, Gujarat, pioneering IVF consultant and many firsts in her name, awarded the prestigious FRCOG Distinguished Service Medal, founder, chairperson of Endometriosis Committee of FOGSI, and chairperson of Endometriosis Committee of SAFOG, several IVF centers across the country she is governing, and the president of Gujarat chapter of ISAR, published 14 books, and peer reviewer of Jogi, JRSCB, editor, European Journal of Endometriosis, member of National Advisory Board of Journal of Human Reproductive Sciences.
Yeah. So thank you so much, Dr. Ramani. It was such a kind introduction, and I never expected that we will have so many participants in the essay competition. We had around 17 entries, and reading 17 essays, and very well written, I think, by most of the contestants. And some of them had written like how it's given in a textbook, very this essay competition was very interesting because we had 17 contestants altogether, and all these participants had written in very different methods, I must say, and a few of them were really not up to the mark, and I was a little bit disappointed reading those. But at the other hand, few of them had written extremely well. I was really overboard, and two of them had really excelled in writing. I think when it goes to writing an essay on a difficult scientific topic like endometriosis, and also in view of the diagnosis of endometriosis, which is once again very, very difficult. So they have done a good job, I must say. And what I liked about few of the, I don't know whether they're girls or boys, but then I think in the quiz, the girls have really superseded the boys. And logging in. So, in the first thing I want to tell you what really I liked about few of the the essays. The way they have written was very nice, very artistic. So I feel every field of medicine is not only science, but it has a bit of art as well. So the way they wrote their English and the knowledge about the subject, and covering each and every part of the diagnosis, right from how they enter the OPD, how they tell the history, even the mothers tell the history, how, what type of clenching pain they have, and so the history taking is very important. The clinical examination is very important. So each and everything is important. It's not only the newer methodology of diagnosis. Of course, that is also important. So how I especially judge was giving equal importance to the art of writing, the methodology, how much deep knowledge they have in each of the aspects. Like as I told you, diagnosis is not only the technology, this biochemical tests, etc., but also history taking, clinical examination, all that, and cannot miss on anything. And then also how important is the sonography, ultrasonography, and where the rectal is needed, the MRI, how important is MRI, etc. And then going to the markers, and and then laparoscopy. So those candidates who really completed everything and also written like an essay. It should not be written like like a PPT. So that also I have taken in consideration. But anyway, I enjoyed reading these essays. I think it was like a revision for me in the diagnosis of endometriosis. And I think this topic is very relevant in today's era, because the earlier we diagnose, we can really control the disease in a really good manner. So I request the other the judges to please give their comments for the same.
I'd like to say a few words on the particular area. As Dr. Bansal has already highlighted, I've been overwhelmed to see the 17 participants were there. But the nature of writing was different for each participant. Some of them has written just like one essay, and some of them have written just like a textbook. So it is an essay and not textbook. That should be kept in mind. Secondly, the important points of diagnosis starts from its apprehension, and then history taking, clinical examination, then non-invasive methods, and lastly, surgical intervention to complete conclusive diagnosis. But this area that to apprehend that this girl might have endometriosis, this awareness, this has been omitted by most of them. The fact is that the disease actually starts much before its clinical appearance when the patient comes to us. At least there is a gap of around 10 years onset in detection interval. So it should be kept in mind that awareness and to catch these girls very early in their adolescent period is very important, and that should have been highlighted in this essays. And that is what most of us are doing in our various awareness programs in schools and adolescents, those adolescent population, to catch those people very early. Secondly, as the incidence of adolescent endometriosis is as high as around 35 to 40% at the moment, and it is going up and up. So that area is to be taken into account. So earliest detection, I feel, is most important. Then, regarding the mass screening, as I've already said, other methods, those upcoming methods are not at all available in our hand. These biomarkers and all, those are not available at the moment in our hand, and those are not 100% reliable. So we'll have to rely on our awareness programs and mass screening. We should have been there. And then regarding adenomyosis, that has not been highlighted by most of the participants, but nowadays we find adenomyosis along with endometriosis in most of the younger girls as well. The place of adenomyosis and its diagnosis should have been there. Even in laparoscopy, glimpses of laparoscopy you can easily identify one posterior endomyosis, apart from various endometriotic lesions throughout the pelvis. So that part is a little bit missing in some of the presentations. Then another point, what made me a little bit disappointed, that the topic is the diagnosis of endometriosis, not its etiology, neither its pathology. And many of them have written the etiology, some of them have written the pathology, pathogenesis, and many of them have, even they have written the management as well. So those are not needed. You must remember what you are supposed to, what have been, you have been asked to write, not the entire thing. So that will cause the negative marking to you. Those points should be kept in mind. Otherwise, it has been fantastic experience to be a judge of this type of essay competition, and I congratulate the winners. I don't know, that must be announced soon, but some of them have written very nice way. And another point, that is regarding laparoscopy. Well, the concept is changing. Instead of waiting for a long time with the idea of this outcome of this imaging and other things, one should go for early laparoscopy. Early diagnostic laparoscopy can cut this onset detection interval to a lot. And that is one area I would like to stress upon. And this endometriosis and adenomyosis, both are there, and those are appearing almost all age, apart from not only adenomyosis, the disease of later age, endometriosis of various stages, that is a disease of earlier age. No, that is not so at the moment. Those points should be kept in mind and should be written accordingly. Otherwise, it has been a great experience, as I have already said. Rather, a good recapitulation from my end also to read all those things, and I'm rather happy to be a part of it. And I thank Dr. Ramani Devi to invite me to be a judge of this particular presentation group, and thank the entire team to come out with such type of conference from the FOGSI's then is a great endeavor, I must appreciate.
Dr. Venugopal, sir.
Yeah.
Would you like to speak about the essays?
No, I just had an experience in coordinating, and I have forwarded it to the judges, and we have judged it in a most impartial fashion as it could be possible. All the judges had been blinded, and all the candidates also, we just numbered it as essay number 1 to 17. And to Kanthi ma'am and Mitra sir and Mahapatra sir, I think they were very prompt because we gave them very less time, but still I think they have been very prompt and frank in their judgment. So I have received all the entries and it has been compiled. So 100 marks each of the judges scored, and out of 300. Only thing is, I think if Ramani Devi madam mentioned that the results will be declared during the valedictory. So that part of it, I think I need clarity. If it's okay, I'm ready with the results. So I think we need to ask Ramani Devi madam about that.
Okay.
Yeah.
Yeah, we'll need to ask her.
She specifically mentioned that that will be declared during the valedictory. So,
Dr. Venu?
Yes, ma'am.
No, Dr. Venugopal, have you done it? You have
done everything is ready. If Ramani Devi madam says, I think she could announce it because I thought.
Because all the other, no.
Because quiz, this quiz result.
Yeah,
quiz result has already been announced.
I think we can announce now, Madam Kanthi madam, because everybody will be eager.
Yes,
because the quiz results have come out.
That is what I'm telling. The quiz result is out.
We can tell this also.
Yeah.
We can again announce it. Dr. Ramani can again announce it in the valedictory also.
That's right. In the valedictory can be announced. No problem.
Otherwise, it will be too much. They'll be anxious, the contestants.
Yeah, that's true.
So shall I just read out the names of the winners?
Yes,
Or Ramani
yes.
Madam, you want
Yeah.
to share? Yeah. So first, we marked at 300 points. Okay. So first, we the first position with 227 points goes to Lieutenant Commander Dr. Afia Safir Kadi from Armed Forces Medical College, Pune. Dr. Afia Safir Kadi from Armed Forces Medical College, Pune.
What was our code number?
Has he logged in?
4.
Code number 4.
Yes.
Do you want me to promote Afia Safir?
Yeah, if he
Yeah,
is there,
if
we would like to see
there,
him.
then yeah.
I still remember whatever she had written, the way she had started writing the essay. I was floored, really. Very nice.
I have also given you a very good mark. Given her a good, very high
I
mark.
think we all judges have the similar, wavelength.
Yes.
Dr. Mitra, I think.
Yeah.
Yeah. I could see that almost the wavelengths ran similar, and there was not much difference in the way.
Not more. Achha. That is what I wanted to see.
Yes. Now the second one.
So
shall I
Dr.
announce the name?
Afia,
Yeah, Dr. Afia, are you there?
if she's there, then yeah, we can see her.
Yeah, I
And
can see her. Yes. Oh, that's all.
that's
Can
nice.
you
You can
put her
also
in the
speak.
speakers? I can't see her.
Yeah, can you speak, Dr. Afia?
Can we put her in the speaker?
Yeah, she's in the speaker. She has to speak only.
Good evening, ma'am and sirs.
Yeah, right.
There's my iCard, there's my service iCard.
Oh, that's okay.
Afia. Okay, fine, fine. Congratulations, Afia.
Thank you so much, sir.
Congratulations.
Congratulations.
Thank you, ma'am. Thank you, sir.
The second position with 220 points. Okay. That goes to Dr. Vignesh D from Jipmar, Pondicherry.
Okay. Code number
13.
13.
Dr. Vignesh D from Jipmar, Pondicherry. Is he there?
If he's there, he should raise his hand.
What's the number, Venugopal?
13.
Sir, speak out the name again.
Lucky for 13.
Yeah. Vignesh D.
No, I don't think he's there in the attendees.
Yeah. Now the third position with 215 points goes to Dr. Ambika Shankar from Savai Mansingh Medical College, Jaipur. Ambika Shankar from Savai Mansingh Medical College, Jaipur. That is code number 6.
She's my candidate.
Yeah, I've promoted.
She's my postgraduate student.
Lovely.
So congratulations. You also, Oby.
Yeah.
You deserve congratulations.
Congratulations, all.
Thank you.
So we have promoted her to. Is that Endo 1004? Is the same
Shankar.
name? Ambika Shankar.
Yes.
You have been promoted.
Yes, ma'am. Hello, ma'am. I don't know whether my video is coming.
Yeah, we can listen to you. Loud and clear.
I don't know why the video is not coming.
Video? Yeah, now it is coming.
Hello.
Start.
So everyone, this is my iCard. Thank you so much, ma'am.
See her.
Thank you to everyone.
Congratulations to all.
Congratulations.
Congratulations.
Thank you, ma'am.
But ultimately, I believe everybody who participated as a winner, I'm sure the judges will agree to that also. That everyone who participated is a winner, because I think everybody deserves a round of applause. Yeah. And a big thanks to Ramani madam and this whole team.
Okay. Yeah, this one is for all the participants.
Yes.
Pardon?
This applause is for all the participants.
All the participants. On my behalf and Dr. Oby and Dr. Neharika, all of us were coordinators. We enjoyed that small role. Thank you, Ramani madam, Kanthi ma'am, and Asha ma'am, and all for giving us this chance to do. Thank you.
Thank you so much.
Nice.
Thank you so much.
Thank you.
So thanks to all the organizers for this particular competition and the judges for judging it and giving it in the right time. So shall we move on to the next one?
Yes.
Yes.
Next one is for the poster and the paper competition. We have the coordinators, Dr. Asha Rao, the chairperson of Endometriosis Committee of FOGSI 2020 and 22. And she is the director of Rao Hospital. And her center is being approved by MGR Medical University for fellowship, postdoctoral fellowship in reproductive medicine, delivered the first ICSI baby, past president of Coimbatore OBGYN Society, under whose guidance we had the excellent FOGSI South Zone last year. I think everybody will remember that. And she is also the organizing chairperson of IAGE Star Endocrine Conclave in 2019 and recipient of President of India Gold Medal, and trained at London and Brussels under world-renowned experts in ART. It is a pleasure working with you, Dr. Asha, madam. And the next person is Dr. Subash Mallya, young upcoming gynecologist of Kerala and a good friend of mine. I should say, I don't know whether to say it as a friend or something else. Consultant gynec minimal access surgeon in DNB guide from PVS Hospital and Baby Memorial Hospital of Calicut, zonal coordinator of FOGSI President 2020, secretary of Calicut Society, managing committee member of IEGE, FOGSI Mentor Mentee awardee in 2019, member FOGSI Endoscopy Committee, and he is currently he's going to be the incoming chairperson of Endoscopy Committee of FOGSI. Welcome to the FOGSI family.
Thank you, madam. Thank you very much for the warm words.
Yeah, published so many papers in index journals. Next person will be Dr. Priyankur Roy, again the young boy from the rising sun, that is in the east direction of our country. And he is a consultant in infertility and endoscopic and no IVF and Roy's Clinic Siliguri. Indian representative to Vatang FIGO in 2018-21, National Coordinator for Perinatology Committee, E-Zone Coordinator for Infertility, Endocrinology Committee of FOGSI, Joint Secretary of Siliguri OBGYN Society, and E-Zone FOGSI 2020. He is going to be the organizing secretary. Then published many articles, peer reviewer of various journals, presented more than 50 articles in various conferences, achieved numerous awards. To say a few, he has received 3 FOGSI awards in this current year, and I welcome Priyankur. And whenever I call Priyankur, immediately he will say, it's done, madam. That's all, the only answer he will say. Welcome you, Priyankur.
Ma'am, thank you for the kind words, ma'am. Thank you.
So let us move on to the other.
Thank you, Dr. Ramani Devi, for those kind words. And I would say that I'm really privileged to have you as the Vice President in charge of Endometriosis Committee. Thank you so much for all the guidance and your enthusiasm that you have been infusing. So as the Chairperson of Endometriosis Committee, I'm privileged to be the Organizing Secretary of this International E-Conference on Endometriosis, Endometcon-3, which was organized over a very short period with so much enthusiasm from Dr. Ramani Devi and Kanthi Bansal. And it is our motto this year from Endometriosis Committee. Our motto is think endometriosis and fight endometriosis. And I think this conference is really, really going to help us to spread awareness on endometriosis all over India and maybe even outside India. And now we come to the paper presentation competition, paper and poster. And we are extremely lucky to have 3 experienced judges. And the first one is Dr. Muralidhar Pai. I'm glad to welcome you, sir, Dr. Muralidhar Pai.
Thank you.
He was rather busy with some other program, but he has pushed it aside and given priority to the Endometriosis Committee programs. Thank you so much. He's the best outgoing MD candidate and topper in DGO from Manipal, 8 times best teacher, 3 times Teaching Material Award from KMC Manipal. His author, Holland and Bruce Manual of Obstetrics, 4th edition of Obstetrics and Gynecology, 1st edition. Corresponding national editor and jury of Best Article Award. He's the national chairman of FOGSI Public Awareness Committee 2004. And he has won so many awards. Also he has done fellowship in infertility, and he has 172 publications, 458 presentations, guest lectures. We have always enjoyed his very, very clear presentations. And we are lucky to have you here. So welcome to you, Dr. Muralidhar Pai. And I know I can talk for another 10 minutes about your achievements. Thank you so much for being with us.
Thank you, ma'am.
I think
Hi,
Dr.
yeah. Hi, ma'am. It's my proud privilege to welcome Dr. Vidya Achutrao Toby, madam. Madam is the professor and head of the Department of OBG at Alamin Medical College. She's also with the Deputy Superintendent of the Alamin Women and Child Hospital also. We all know the wonderful work that madam has done in the last 3 years with the Food and Drug Medical Surgical Committee. And madam has given a lot of opportunities to a lot of youngsters all over India. And she's been very, very active in even before the COVID times came out and we had a lot of e-conference. She was very much active on the ground. She used to travel to a lot of places and conduct a lot of conferences. I think she's really brought a charge into this particular committee and can see the amount of people who wanted to be the committee chairperson this year. I think she's really got a lot of zeal into this committee. And she's been the national corresponding editor of Jogi, and also she was awarded the FICOG in 2012. She's been the treasurer of Kasoga, EC member of Kasoga. She's also been a very active member in the social circles of Bijapur also. I welcome Dr. Vidya Achutrao Toby, madam, for this conference. Over to
Deepika, can I have the next slide, please? Yeah, it gives me a proud privilege to now welcome Dr. Neelam Mishra, ma'am. Ma'am is from Kanpur. She's presently the president of the Kanpur Obs-Gynae Society. She's a director and chief consultant at Shivani Hospital, and she has a special interest in minimal access surgery, hysteroscopy, as well as infertility. Member of the Indian Association of Gynecological Endoscopists. She was awarded the Nari Shakti Platinum Icon Award for her contribution to women's health. It's really, ma'am, a privilege for us to have you here, because saying this, endometriosis is one of the primary concerns for a woman, and we all as doctors know how much it feels, how much it is worry for a woman to have this disease. So it's a real privilege to have you here. Then she has also organized many workshops, conferences, and she was the organizing chairperson of the endosurgery in UPCOG in 2015 and organizing secretary of endosurgery in WWWCon in 2018. She has been invited faculty of many international and national conferences and workshops. So it's a privilege to have you here, ma'am. Actually, to have all the three judges with us, Muralidhar Pai sir, Dr. Neelam Mishra, ma'am, as well as Dr. Vidya Toby, ma'am. So now to start over the session, I request Dr. Subash Mallya to kindly introduce the first candidate, and then we start over the session. So before we start, just think for the candidates as well as the judges. So basically, we have totally 6 candidates that has been shortlisted for the oral paper presentation. A total of 7 minutes will be given for presentation to the candidates and 3 minutes for question answer session. That is 1 minute each for each of the judges. So so that is it. And the times, there's strict marks for the timing. So candidates, please make sure you finish within 7 minutes.
And we're only going to call the candidates and not introduce them really.
We'll call the candidates. Yes, ma'am.
Yeah.
Yes.
Yeah, without wasting any much time, I would like to welcome the first candidate, that is Dr. Bishita Pakchi. Dr. Bishita, it's all yours.
Good evening, everyone. I'm Dr. Bishita Pakchi. I'll be presenting manuscript on finding a simplified clinical score for diagnosis and treatment of endometriosis without chocolate cyst. The background, basically, endometriosis, as we all know, is a debilitating chronic inflammatory disease affecting millions of women of both the adolescents as well as the reproductive age group. Prevalence is about 47% according to the previous literature, but if we go together, both endometriosis and infertility, it's as high as 50%. Clinical history, examination, and imaging especially ultrasound. Both transabdominal and transvaginal ultrasound has been considered as a cornerstone for screening of endometriosis, and the recent trend of diagnosis by these non-invasive procedures have been supported by the regulatory authorities as well. Objective of our study was to find out a correlation of clinical symptoms, including the USG findings, if it can be used as a screening tool to detect early endometriosis without chocolate cyst. In our setup, around 27.6% of the patients who had undergone laparoscopy as investigation for infertility, and 85 of them were found to have endometriosis on laparoscopy. In our study, around 30% of the women over a period of 60 months from 2014 to 2018 had come to us with complaints of painful cycles, with dysmenorrhea, chronic pelvic pain, irregular cycles, and early menarche. And 90%.
Ishita, can you hear us?
Yeah, she was saying that she had some problem in Calcutta,
Yeah.
Lake City. What do we do?
We'll go to the next speaker, Abarajita. When she comes back, we can ask her to present again.
Is Aprajita ready?
Yes, madam.
Okay, fine. Yeah, we can see your face. Yes. Okay, fine. Your net is all right, I suppose. Good, you can start.
So if we go by the clinical scoring system, what we had done was considering the clinical symptoms, the family history of the patient, clinical findings, and the clinical signs and the USG findings. So we had given a score of 1 each for each feature. So we had considered dysmenorrhea, dyspareunia, and chronic pelvic pain for clinical symptoms, family history in first or second degree relatives, and clinical findings as per transabdominal or transvaginal and ultrasound were displaced uterus, uterus pulled to one side, retroverted uterus, a restricted mobility of the uterus, tenderness or nodules in the POD. And these were the clinical signs, and the USG findings were distorted anatomy of the uterus, ovarian adhesions, and thickened POD or tenderness in the pouch of Douglas. Laparoscopy scores were given. If one feature was present, we had given a score of 2. So anatomical changes of the uterus, acute retroverted or anteverted, pulled to one side, was given a score of 2. Surface and ligament involvement, that is thickening of the uterosacrals or the if the anatomy was distorted for the tubo-ovarian relationship involving the infundibulopelvic ligament or the thickened Macken-Roth's ligament, ovarian involvement as per variegated ovaries or adherent ovaries being adherent to the uterus, or the POD involvement being obliterated POD or the pseudocavitation, each were given a score of 2. So if we go by the results, this bar graph shows a combined clinical score clustered by laparoscopy and the clinical score that we had got with history and the USG findings. Laparoscopy score of 2 was corresponding to most of the clinical score of 1 to 3. Laparoscopy score of 4 was corresponding to 7 to 9, and only patients with laparoscopy score of 6 and 8, which was who had 3 or 4 features of endometriosis on laparoscopy, had also a higher clinical score of 10 to 12. If we go by the USG and the laparoscopy score, it corresponds the same. A laparoscopy score of 2 was in the zone of USG score of 1 and 2, and laparoscopy score of 6 and 8, which was higher, like 3 or 4 features on laparoscopy were seen in the USG score of 3. That means those patients had at least 3 features on USG for diagnosis of endometriosis. This is a contingency table involving the laparoscopy score and the clinical score and the USG score, where the percentages can be seen. Clinical score of 1, 2, 3, around 13.5% of the patients had a laparoscopy score of 2, that is only one feature on laparoscopy. 12.5 and 12.9% had a laparoscopy score of 1, 2, 3, like 1 to 3 or 4 to 6 in the clinical score, had only 2 features on laparoscopy. 26% of the patients who had 3 features of endometriosis on ultrasound had a clinical laparoscopy score of 6 to 8, that is around 3 to 4 features on laparoscopy as well. If we go by the management, we can say that the clinical score of 1, 2, 3, around 29.2% of our patients had this, and it's considered as the most possible zone where we can go for a trial treatment of endometriosis. 35% has a score of 4 to 6 with most probable zone, in which we can go with the medical management, and laparoscopy can be easily avoided. And diagnostic laparoscopy is not at all required if the score is more than 7 in the clinical score, 7 to 9 or 10 to 12, because here we can actually go ahead with the definitive treatment of endometriosis. Delay in the diagnosis and deterioration of quality of life is noticed in women with endometriosis, and it mandates early intervention. As of now, USG, transvaginal ultrasound, transabdominal, and MRI being the non-invasive techniques, patients also comply really well, and these are also well accepted by the patients to screen ovarian and non-ovarian features of endometriosis as well. So TVS and TAS being the first-line imaging modality in evaluating patients with suspected endometriosis, especially in adolescents and in young infertile women for whom surgical intervention becomes a nightmare. Abdominal USG in young sexually inactive women have also been proved to be quite useful in diagnosis or screening of early endometriosis, and we can actually intervene and manage them by this. POD thickening or on pelvic ultrasound by abdominal root or tenderness in the POD on TVS has been shown as a very promising feature of endometriosis in our study too. So real-time dynamic TVS evaluation has been established as a high degree of certainty. Whether the POD is obliterated or not has also to be considered to point out higher risk of bowel endometriosis. The only limitation of this procedure is it is heavily operator dependent. We can conclude that the clinical symptoms signs with USG findings have been seen to be quite helpful to screen the endometriotic cases, and in extremely doubtful cases we have to go in for laparoscopy. And it is very important to note that the clinical score and the USG score corresponds to a large extent to the laparoscopy score as per our statistics. Primarily in infertile women, finding a clinical score for diagnosis and planning of treatment of endometriosis can help us treat the hellion behind the blow. Our paper has been published in International Journal of Medical and Biomedical Sciences recently in April 2020. Thank you very much for your patient hearing.
Just please note, she has finished in 5.5 minutes.
Okay, what is the order of asking questions?
Anyone, Muralidhar, you can take over. No problem.
Yeah. Congratulations, Dr. Bishita. Also, because it's already been published.
Yeah.
And it was a good study. And can you just tell me in one sentence what is the novelty of the study?
So basically, we want to say that in cases of infertility having endometriosis, if we go in for a laparoscopy only for the diagnostic purpose, it leads to a lot of adhesions, and if the anatomy is still normal, it gets distorted because we had intervened for that. So if we can manage, like if we are sure enough with the clinical score and the ultrasound findings, which is like non-invasive procedures, and we can go ahead with the treatment and treat them before we treat them for infertility, manage the endometriosis, and then if we do it, then I think the results will be better. So it's like least intervention, and even convincing these days patients for laparoscopy is a big thing. And especially for young and these adolescent the parents are very conscious and they are like very scared, like for laparoscopy, that the little girl 16 years 18 years they are going in for any laparoscopic procedures. They usually do not agree what we have seen in our clinical practice. So if we can manage them, like treat them with the same medications for that, then I think it's easier. I mean, it's easier in both ways, both clinically as well as.
Yeah, I agree with you. All the recent studies say that just for the purpose of diagnosis,
exactly,
there is no need to do laparoscopy, even though we always said laparoscopy is the gold standard.
Gold standard for endometriosis,
But
definitely.
it's not needed just for the purposes of diagnosis.
Yes.
If you are planning to do surgery,
That is a different thing. That's why we had excluded the patients with chocolate cyst.
Correct.
So that, yeah.
That's the only indication for laparoscopy. That is, if you are planning to even include surgery, otherwise just for the purpose of.
Yes, sir.
Would you like to do CA 125 in these girls and rectal ultrasound that can give much better accurate diagnosis in unmarried girls?
We do a rectal examination.
Yeah, in adolescent girl, TVS is not possible.
Yes, so what we have seen is abdominal ultrasound also we get POD thickening, the shift of the pulling of the uterus on one side, the ovaries being the adherent or kissing ovaries, what we see in endometriosis usually. Those things are seen on abdominal ultrasound as well. So rectal ultrasound, they usually don't agree, ma'am. So that's a problem. So
what about CA 125?
CA 125 is usually elevated in endometriosis. So for a screening purpose, we can do it, but it will not help much in the management.
No, but about when you give the treatment, you can get it and you can tell.
Yes, for the prognosis purpose, we can definitely do
or
it
not.
and then treat them with the medicines and then again repeat it and see that way. That is fine. But for the diagnosis thing, it
No,
is not.
not for diagnosis. After all, we
Yes,
are
ma'am.
going to treat
Prognosis
this guy.
definitely.
Yeah.
Yes, ma'am. Yes, ma'am. We had not done it routinely though. We were mainly doing it on the history and the imaging findings. So that way.
It was a good presentation, Bishita, and it is a really
you,
novel
ma'am.
one. And this one, laparoscopy is a gold standard, as all of us we know. But any cases you got in this that there are clinical and USG pictures they are showing, but you could not pinpoint on laparoscopy. So any negative laparoscopy findings you had in any cases, like sometimes they are infiltrative deposits and which you cannot diagnose on laparoscopy, but you have diagnosed on ultrasound, or how many of they have MRI done in this?
Yes, ma'am. If
Have
we
you
see
done
one
any
feature
MRI?
on like ultrasound in this corresponding, we see the similar kind of like if we try to stage it, like if it's mild or minimal, like we have one or two features on clinical findings and USG, and we have like one or two features on laparoscopy. That's why the table was put in that according to our statistics, it is correlating with that. That was the most interesting part. Like if we want to see like if it's mild or minimal that way, because we had restricted our study to stage 1 and 2. We had not gone to, we had avoided the patients with endometriomas. Those were our exclusion criteria. So it had correlated. That was the whole point of the study. That, yeah, definitely if we are doubtful that in a USG we are not able to find anything as such, we had patients like that we had to do a laparoscopy for infertility purpose, and then we saw, yeah, there are like endometriotic spots scattered in the pelvis or in the POD or somewhere, and then we had to accordingly treat them. That was there. But like on a general count, if we go by our statistics, it actually correlated. That was the best thing actually what happened. So we plan to write it down and publish it so that it's known.
And very nice that you have put at the bottom that limitations of the studies. It's observer dependent. Yeah.
Ma'am, that's what it it is heavily operator dependent. People other than gynecologists, if we leave these to radiologists, it's a little difficult. Like
Just one.
Wants to comment. Yeah.
Just one question. Last question.
Yes.
This the scoring system was devised by you only, and was it validated by somebody?
Validated. Yeah, that is most
validated. No, like we ourselves tried to design it depending on the clinical
No,
findings.
it's good. I'm not. I'm just.
We can through the endometriosis committee, we can do multiple.
It will be a pleasure, ma'am. It will be a pleasure.
Okay.
If you want to see, and if you want our manuscript, this stats also, we are ready to send it to you. If you can do it, it will be a great pleasure for me as well as my senior consultant.
Validation, yeah.
At which hospital was the study done?
Yes, ma'am.
At which
Asha is asking which
West Bengal, ma'am. West Bengal.
Calcutta Fertility Mission.
Calcutta Fertility Mission.
Very nice. Please share your article which is published. Okay, for us.
I think now we have to move on to the next.
Do I share it in the chat, or how do I?
You can share in the chat for the people.
Okay, ma'am. Sure, definitely. Thank you so much.
Chat also in the group.
Please in the group also.
Okay, definitely. Okay, thank you so much.
Can we move on to the next speaker or presenter?
Yes, ma'am. Let me call upon the next speaker, Dr. Abhirajita.
Yes, sir.
Ma'am, please share your screen and start your presentation, please.
Yes, sir. Is it visible, sir?
Not yet.
Not yet.
I have clicked the share screen button, sir. I think they have to allow me or something like that.
You are allowed. You can. Everyone is allowed to share.
Please
Is it seen, ma'am?
Please try once again.
Give them host, they cannot.
Dr. Abhirajita, you first please open the PowerPoint presentation. Then
Yes, sir, I've opened.
Then share screen. You will see a small pop-up of PowerPoint. Click on that and it will open up.
Okay, sir. I have opened the PowerPoint, sir.
Yes.
Yeah,
now you open
your green color, ma. Green color on the top. Share screen.
Yes, sir. I've clicked it.
You see the pop-up of PowerPoint?
Yes, sir.
Click on that.
There's no pop-up of the PowerPoint, sir. It's just the share screen.
Priyankur, you have the presentation, Priyankur?
I don't have it.
Okay.
Okay. I'll talk to her. I'll get the presentation here and I'll share it.
Okay,
sir.
Then next presenter, please.
Yeah, you can mail it to Priyankur or...
I will talk to her, ma'am.
Yes, okay, sir.
Yeah, next let me call upon third speaker, Dr. Elizabeth Lucas. Elizabeth, are you there? Elizabeth?
Yeah.
Yeah, you please start your presentation.
Mr. Priyankur sir has to put my PPT.
I have to put your PPT.
क्या आपके पास Priyankur?
I'll just check it. 1 second. Elizabeth, you have it? I don't have your PPT.
I have already mailed you.
Okay,
I've already mailed you.
Dr. Subash, can you please move on to the next one? I'll just check.
I would do that. Asha madam? Yeah, do we have the next speaker, Dr. Geeta, ready? Dr. Geeta?
Sir, I have Dr. Elizabeth's PPT.
Fine, Deepika madam, can you please? Yeah.
So would you want me to?
Yeah, I think if the judges allow me, then may I continue with Dr. Elizabeth, Vidya madam, Neelam madam?
Yes, no problem.
Yeah, okay, ma'am. Yeah, Elizabeth?
I'm just going to share it. Please hold.
Yeah. Elizabeth Lucas?
Yeah.
You ready?
Yes.
Can I start?
Yes.
Hello?
Yes, you can start your presentation.
Hi, everyone. I'm Dr. Elizabeth. I work as a junior consultant in Devi Memorial Hospital. So mine is a case report, which is on spontaneous hemoperitoneum in a patient with unscarred pregnant uterus. Basically, what exactly is spontaneous hemoperitoneum in pregnancy? It is defined as a blood within the peritoneal cavity of a non-traumatic etiology, which is a very rare event, especially in a woman who has a history of endometriosis and especially undergone an IVF pregnancy treatment associated with very high perinatal mortality, and which is apparently very clinical, difficult to suspect and diagnose. It is most often picked up in the ultrasound imaging in patients presenting as acute abdomen and abdominal distension or with anemia. Etiology till now date, it is unknown, could be multifactorial, but the trigger of the spontaneous bleeding has not yet been established. This is a case report of my patient who is a 38-year-old elderly primary gravida who is married for 7 years. She's at her 27 weeks of gestation to us from a rural area. She was treated for ICSI pregnancy. She had undergone an ICSI pregnancy. She's hypothyroid. That's the only medical condition she has. And she didn't have any other history of trauma, intrauterine or extrauterine manipulation. Means, in spite of undergoing treatment for infertility, she didn't have any history of hysteroscopy or laparoscopy. And her presenting complaints in the casualty was abdominal pain since 2 hours and reduced fetal movements. And apparently she had presented to us in a state of shock. On clinical examination, there were signs of anemia. She was tachycardic, 148 beats per minute. She was hypotensive on inotropic support. Her abdomen was tense, distended, and tender. And uterus on palpation was tense and tender. Abruption, or it could be rupture uterus. We went ahead with taking a high-risk consent, and we went ahead with a plan of going for emergency laparotomy. And before that, we made it sure that we do a USC and a CDC, which was suggestive of intrauterine death and intrauterine fetal death and moderate hemoperitoneum, with her HB being 6.4. So we put on with the necessary blood investigation, and 2 wide bore cannula was inserted, and this was already arranged and started. We explained the patient's relatives about all the possible complications, placenta abruption, rupture, need of laparotomy explained. So we rushed her to the OR. Senior surgeons and multidisciplinary approach was being sorted to, and the surgical findings. The laparotomy was done. It was a massive hemoperitoneum, approximately 6 liters of blood. The moment we opened up the abdomen, the uterus was such a way that was so distorted with adhesions. It was literally buried in adhesions and with diffuse ongoing blood. Not make out where exactly the blood was coming out. So what we did is we did adhesiolysis. We did dense adhesions between the urinary bladder and the taken out with a sharp dissection. Hysterectomy with adhesiolysis, and there was it was a stillborn female fetus, 3 grams, and there were diffuse endometriotic implants all over the uterus. When we opened up and delivered the baby, the lycra was absolutely clear. There was no signs of makeup. There was only endometriotic implants all over the uterus. There was no evidence of abruption since the lycra was clear. So we continued with the
Elizabeth, we cannot hear you properly. Elizabeth, please put off your video.
Hello?
Elizabeth, please put off your video. We cannot hear you properly. Switch off your video. Yeah, now we'll be able to hear you better.
So we literally did the adhesiolysis and we exteriorized the uterus. There were multiple rents, 5 into 5 centimeter fundo-posterior wall and 2 into 2 centimeter on the either lateral side. We repaired it into 2 layers. Uterotonics and blood components were given, and abdomen was closed in layers. Drain was inserted, and clear urine was observed in Foley's catheter. She was being kept in ICU for 3 days on IV fluids, antibiotics, and drain care. In total, 7 units of PRBC, 4 units of FFP, and 4 units of platelets was transfused. And on POD 11, she was being discharged in good general condition after being counseled about the future pregnancy crisis and the possibility of rupture uterus, which was about 32-fold. Now, coming on to my discussion, which is spontaneous hemoperitoneum in pregnancy, which is a very rare and life-threatening event, which is normally being seen in a woman, normally in a primary gravida, who's undergone an infertility treatment with IVF pregnancy. And there were many papers being established. One of the papers was which I had quoted in the PPT, the spontaneous rupture of the uterine vessels. And apparently, till date, the etiology is not yet been established. There were many theories which were played, among which the most awarded one was the progesterone resistance in endometriosis, the link to failure to metabolize estradiol. So this was my case where we sent certain biopsies from the peritoneal wall, and it was seen that the decitalized stoma and ruptured vessels on the serosal surface of the uterine fundus. And apparently the lumen of the blood vessels were distended with the disintegration of the vessel wall. And the only thing we could come up with progesterone resistance, suboptimal expression of the target genes. Possibly could be due to functional progesterone withdrawal, triggering the involution of the decidual phenotype of ectopic endometrium, surrounding the distended parametrial arterioles, leading to peritoneal bleeding of unpredictable severity. In our case, it was such an emergency, patient was shocked. USG was the only thing which was beneficial. Strong suspicion of uterine rupture was there. That is, we went ahead with emergency laparotomy. And the rupture of uterus is a strong possibility in a pregnant woman with hemoperitoneum with menstrual history suggestive of endometriosis with or without a history of previous cesarean section. In this case, it was an unscarred uterus, but still we came across with a rupture one. So my conclusion is, evidence suggests that during pregnancy, a link exists between ectopic destabilization, particularly that occurring in an endometriotic foci, and the occurrence of SHIP. Alteration in vessel wall have been demonstrated, relevant biopsy been obtained. Arterioles can become modified in the absence of trophoblast. Vascular alterations were seen at the site of bleeding, and subclinical decidual bleeding may be a potential risk factors for the preterm labor. Further clinical and pathological and molecular investigation is still required to get into the etiology. These were my references. Thank you.
Judges, please note she has finished in 6 minutes, 45 seconds.
So can you tell that what post-operative management, how you will be following up and whether you have followed this patient?
Yeah, we did follow, madam. Actually, she didn't ever give us a history that she was being treated for endometriosis, but her symptomatology was consistent with endometriosis. So we told her about her future pregnancy and for the treatment of endometriosis with medical management. Because since we had already done adhesivolysis, so we put her on mifepristone analogs and treated ahead. She's still in our follow-up.
Congratulations, Elizabeth. It's really a rare case, but I'm a bit confused in the sense the relevance of this case in this particular conference. Though you have mentioned it is endometriotic case studied with endometriosis at the laboratory, and it could be possibly due to resistance to progesterone. That's why the desensitization has not been complete, and that's why the blood vessels bled. But also at the same time, surprising that with so much of bad endometriosis she has conceived and gone up to around nearly 1 kg, 1.3 or something. Yeah. And I would have really appreciated intraoperative pictures and possibly a video.
Put the picture in the corner of one of my slides.
I saw that one
of my slides. I put a picture at the corner.
I saw that. It was very small picture, not very clear. It was only in one corner. In a case like this, see, when you the previous study, for example, it was just a study where you didn't have much pictures. Although she also could have put some pictures of the laparoscopy to show that how the scoring was done. But your case, which is just a case report, definitely we would have expected beautiful pictures, lots of pictures, and those scary vessels which started bleeding.
I've actually put the pictures in my actual paper. Actually, there are 2 pictures, the clear ones. This is not clear actually.
Yeah,
I have already mailed it to Priyankur, sir.
No, I'm just commenting for a positive way, so that next presentation can be better, not to be taken in any other.
Definitely.
Yeah, it's just a discussion friendly.
No, definitely.
Not as a judge and the. Yeah.
So my only intention to put this thing was. Hello.
Yeah.
Yeah, we are listening.
Yeah.
My only intention to put this thing was
very good. Very
never expected this case.
Yeah, I know. I understand that. Probably you are not ready with the camera also because But anyway, this was not a usual case. It was an unusual case. So I'm sure anybody will have a camera in the OT nowadays with a mobile at least. And a nice video also would have been just for a teaching purpose also, because this comes once in a blue moon or it is once in a way. So however, you have managed it quite well. And I really appreciate that, this case, you could save the patient. And, it was, I hope the baby was also alive. No.
No, actually, it was too late. It was a newborn.
Yeah, okay. All right. So I think that's over to others.
Dr. Neelam wants to comment, I think.
Was she a booked case or an unbooked case?
Yeah. She was a referred case to us, madam.
Okay, so you did not know what were her findings earlier, right? I mean,
she definitely didn't give us a history of all the surgeries, any laparoscopy, or whether she was treated for endometriosis. No, her menstrual history was kind of suggestive, but as such, no other history.
And she was a nullipara.
She was a nullipara. She was an elderly primary gravida.
So yeah, you cannot think of multiple abortions and damage to the uterus.
We cannot say. Yes.
Dr. Neelam, you have something to ask?
Yeah, I had one case previously also, primipara with posterior wall rupture. And there was no silent rupture, but sometime it can happen with this thing. But it's a very nice presentation, rare presentation. It happened with me also once, and she had a posterior wall rupture in a primary para at 34 weeks. But by chance, we have saved the baby, which was diagnosed in time, and we have saved. So it's a nice presentation, something very different presentation, but I don't think, have you got this endometriotic, those biopsies done that time? At the time of surgery, did you got some biopsies?
Yeah,
done?
we got the biopsies done. We got the
taken the
biopsies done.
Positive, they came out to it. Okay.
Yeah, they came out to be positive for endometriosis, for distended vessels, madam.
Okay.
Yeah, we had a case of spontaneous hemoperitoneum in a non-pregnant lady. She's a lady who has had cholecystectomy twice. First time in somewhere else, and the second cholecystectomy was with us. This is about 10 years back. And then she had 2 normal deliveries with us. And she came after 3 years with the acute pain. Beta SAG was negative. Ultrasound showed a lot of hemoperitoneum. And we did a laparoscopy. We saw it was an erosion of the pelvic vessel.
Yeah, it is very
And we had to do internally, ligation laparoscopically, and then the bleeding.
Actually, one of the proposed theory also, the erosion of the uterine artery.
Yes, it was a non-pregnant. She had delivered 2 babies, and it happened to 4 years after the second.
How many cases like such cases are reported in literature? Have you searched?
Madam, there was one Italian thing, and that there were 26 cases, out of which 16 was antepartum and 8 were postpartum.
Okay.
In 24 cases, but the case I came across posterior.
Your audio is stuck, so I think we can move on to the next case.
We'll move on to the next person.
Yeah.
Thank you, madam.
Thank you, Elizabeth. It was a very nice presentation.
Nice presentation.
Thank you, madam.
And next, I would like to call upon Dr. Geeta V for her presentation. We'll give some more time to Aparajita to settle down. Dr. Geeta, please. Is she here?
Yes, ma'am. Now
we are able to see Geeta.
Okay. So good evening, everybody. So today I'll be presenting on my study, which is on endometriosis and ART outcome. So endometriosis affects up to 30 to 40% of subfertile women. IVF outcome in endometriosis, especially regarding live births, is still a matter of debate. So our aim of the study was to evaluate IVF outcome in women with endometriosis and compare the outcome with people who didn't have endometriosis. So it was a retrospective analysis, which was done for a period of 2 years, and number of patients included were about 301. And the study population was basically patients who had IVF at our institution, like endometriosis for male factor, tubal factor, and unexplained infertility. So we compared endometriosis with other factors. People who were excluded were people who had multiple factors of infertility, ovulatory disorders, and who were included in donor programs. So patients were basically divided into 4 subgroups, like endometriosis, male factor, tubal factor, and unexplained infertility. And they were scheduled to IVF, like on baseline day 2 ovarian reserve tests were done for all patients. Fixed antigen protocol was used. Gonadotropins were started at around 150 to 300 international units based on the patient's profile. Ovulation was triggered when there were 3 or more follicles more than 18 mm using HCG or decapeptyl or dual trigger. Oocyte retrieval was done after 35 hours of trigger. ICSI was done, and following which we had embryos frozen. So endometriosis patients were given GnRH analog for pituitary downregulation and were subjected to embryo transfer. So embryo transfer was done in the subsequent cycle when the endometrium was above or equal to 8 millimeter. On 16th day after embryo transfer, pregnancy was assessed by serum beta HCG and was confirmed by transvaginal ultrasound after 1 to 2 weeks. The primary outcome of the study was live birth rate, whereas secondary outcomes were dose of gonadotropins used, mean number of oocytes retrieved, number of M2 oocytes, fertilization rate, implantation rate, and clinical pregnancy rate. So patients were comparable in terms of age and BMI in all the subgroups. Whereas in case of AMH and AFC, endometriosis patients had lesser AMH and lesser AFC in compared to other subgroup, which was statistically significant. In our study, when we analyzed how many patients were in each stage of endometriosis, it was stage 4, which was a maximum. And patients who had endometrioma and ovarian endometrioma were more. And we also saw how many patients had cystectomy prior IVF. About 74% of people had cystectomy prior IVF. And when we analyzed patients who had cystectomy and no cystectomy, we saw that the mean AMH, AFC, and M2 oocytes were lesser for people who had cystectomy earlier, which was statistically significant, whereas other fertilization rate, implantation, clinical pregnancy, and live birth rate did not make any difference. We noticed that the total dose of gonadotropins used for endometriosis were more, which was statistically significant when compared to the other subgroup. And the number of M2 oocytes retrieved, number of oocytes retrieved, number of the fertilization rate when compared with other subgroups were not statistically significant in our case. And when we analyze the fertilization failure rate and cycle cancellation, it was seen more with endometriosis patients. Sorry. And we also noticed the implantation rate was less in endometriosis subgroup, which was statistically significant. And clinical pregnancy rate also was less in endometriosis subgroup. And live birth rate also was less in endometriosis subgroup. And we also studied on the cumulative live birth rate for endometriosis compared with other subgroups, which was statistically significant, and it was less. And we also saw the stages of endometriosis and how it was effect. So we noticed in stage 4 endometriosis, obviously the implantation, clinical pregnancy, and live birth rate was less, which was statistically significant. Coming to other studies, this live birth rate is always a debate. Like there are studies which say endometriosis live birth rate is less, and a few studies even say there is no difference. And but compared to other study, our study says that live birth rate is definitely less. So I would say women with endometriosis had 8 to 11% less likelihood of a live birth when compared to those with other factors of subfertility. This effect becomes more apparent with increasing severity of endometriosis. The endometrium seems to be more affected by endometriosis, as evident by the fall in implantation, clinical pregnancy rate, and live birth rate when compared to the ovarian factors. Like the results were comparable in view of number of M2 oocytes retrieved and fertilization rate. So I would say, though ovarian factor can be overruled by even increasing the dose of stimulation doses or other methods, we also need to concentrate on methods to improve the implantation rate in future by more studies and concentrating more on endometrium as well, because endometrium is also equally affected by endometriosis. These are my references. Thank you.
Congratulations, Dr. Geeta. It was a nice study, retrospective study though. Again, you have proven the same fact, which is compared to other factors, endometriosis is a factor which has got lesser chances of pregnancy even with IVF. So that's a well-known fact. And what I would like to comment is that it is better you do as a next step a prospective study, because the protocols should be similar. Only then the design would be similar. In a retrospective study, there could be sometimes confounding factors. That's why it is always better to match, even though you have matched the age and other factors in your study, you saw that. But in that particular slide, I didn't see any p-value. But rest of the studies, there was p-value, and it was otherwise good. Just allow me to make one comment,
yes,
one suggestion rather.
Yes,
your
sir.
slides were excellent, very
Thank
clear.
you.
They were not at all cluttered anything. But what you did was you used several types of transitions, which is a big distraction.
Okay, sir.
In a scientific presentation, there should be one theme.
Okay.
Yes.
Okay. Sometimes the slides were coming from this side, sometimes they were twisting and all that. So I was interested to know what would be the next slide coming up.
Okay, sir.
Sorry
I'll
for
correct it.
but,
No,
yeah.
no, sir. Thank you, sir. I'll correct it.
Okay.
I think it was an excellent presentation, Geeta. Just I wanted to know why you have not taken the ovulatory factors. You have in the initial presentation, you just mentioned that you have omitted the ovulatory factors.
Yes,
and
ma'am.
you are
So in
yeah.
case of PCO and all, maybe the number of oocytes retrieved will be more. So that might be a confounding factor in our study. So in endometriosis, it might be less. So that's why we excluded PCO and patients who had donor programming. So that is the main reason for excluding those patients, ma'am.
One more thing, did you got every time AMH done before operating endometrioma so that we should know? Because sometimes after removing the endometrioma, it improves also.
Yes, ma'am. Yes, ma'am. Yes. After surgery, always AMH was done. AMH was done.
Before and after.
Yes, ma'am. Yes.
And sometimes it improves with the surgery when there's a large endometrioma and you remove, it has to be taken out.
Yes, ma'am. Yes, ma'am.
Whether you have applied that EFI score?
Yes, ma'am. I mean, actually, for the staging of endometriosis, we did do the revised classification of ASRM. That is how we stage the endometriosis.
In fact, for improving the implantation in cases of endometrium, we should use some things, few things are required, na? Like GSR and all you use for improvement, because there's always implantation failure and deficiency, luteal phase defect and progesterone deficiency. So we can do some few
Yes,
things.
ma'am. So with down, the generally accepted concept is with down regulation, especially for patients with endometriosis, implantation can be improved. So for all our patients, they had down regulation, but still we did not achieve the implantation and all compared to other groups. So I think we need to concentrate, like maybe more studies are coming up by like using letrozole, dynagist, prior embryo transfer, so that those integrin expressions will not be aberrant in view of implantation. And also the aromatase expression, the endometrium and all will be subtle. So that I think we
Question,
need
Dr.
to have more.
Geeta.
Yes,
Why
sir.
do you think the rates are poorer in endometriosis compared to other causes?
Sir, basically there are reasons in endometrium, like these beta-3 integrin expression will be in an aberrant way. And there are also, compared to normal endometrium, in endometriosis, the expression of aromatase is more. And because this is more estrogenic environment. And also we do have these prostaglandins, COX-2 and all that will be more in endometrium of endometriosis patients compared to other people. And also there might be, sometimes they say the delay in implantation window might be there for endometriosis patients, but still if we have to work on ERA and analyze on patients of endometrium, we don't have convincing studies to go ahead with ERA also for endometriosis cases.
Thank you.
Thank you.
But which one is more important, do you think? Is it the oocyte quality or the endometrial factor for implantation?
Both, I would say, ma'am. At least in oocyte, we can give more stimulation, concentrate on some adjuvants, and
There are multiple factors actually. What you said, you concentrate only on the endometrium. As Dr. Asha Madam correctly said with her experience, even oocyte quality is not so good.
Yes, sir. But in this study, it did not make
more pronounced than the endometrial quality.
Yes, ma'am. Yes, but I do agree. But in this study, when we saw, it was, I mean, not statistically significant when we compared with the other groups. So that's why my conclusion was on the other side. I mean, oocytes were all number of oocytes were comparable, whereas in implantation, it was less compared to the other subgroups.
Yeah, I think it will take another day if we continue to discuss, because oocytes may apparently look normal. We may require more studies. So I think let us end this discussion here. Thank you so much.
Thank you. Thank you, ma'am.
And now I call upon the next candidate. I think Aparajita is ready.
Yes, ma'am. My presentation is with Dr. Priyankur sir, ma'am.
Dr. Deepika will be sharing it.
Priyankur, you just share her presentation, no? Please. Yes.
Dr. Deepika is sharing it, ma'am.
Yeah.
And for judges, please note the previous candidate finished in 6 minutes, 40 seconds.
So can I start, sir?
Yeah, please start.
Good evening, everybody. Myself, Dr. Aparajita. I'm going to discuss my study on adenomyosis, ERT, and reproductive outcome. Next slide. According to Punte et al., the incidence of adenomyosis in fertile women is 24.4% and even higher in those with endometriosis, recurrent miscarriage, recurrent implantation failure, and in older women seeking IVF treatment. We have also seen adenomyosis associated with increasing age, dysmenorrhea, menorrhagia, and presence of deep infiltrating endometriosis. The objectives of the studies was to explore the effects of medical or surgical management to evaluate the pregnancy rate and the outcome of the pregnancy in women with adenomyosis undergoing ART. It is a single center cross-sectional study done at ART unit of Rao Hospital, Coimbatore. Patients with adenomyosis who underwent their first cycle of IVF or FOGSI were taken up for the study. We had an inclusion criteria of women undergoing their first cycle of IVF or FOGSI. Adenomyosis was diagnosed by using 2D transvaginal scan. Endometriosis was confirmed by laparoscopy. Exclusion criteria was age more than 45 years, severe endometriosis undergoing ablation, adenomyosis undergoing myolysis, and other indications for IVF like fibroid, hydrosalpinx, or uterine size greater than 12 weeks, women with no fertilization after FOGSI. The diagnostic criteria for adenomyosis using the 2D or 3D ultrasound, we were looking for at least 3 sonographic criteria, either globular uterus caused by overall increase in myometrial thickness, asymmetrically thickened anterior or posterior myometrial wall, poorly defined endomyometrial interface, presence of heterogeneous myometrial area, and myometrial cyst. We also assessed the type and size of adenomyosis. All the scans were carried out by a single experienced sonographer to avoid the inter-observer variation. And endometriosis was diagnosed and confirmed laparoscopically, and staging was done according to the ASRM classification. After applying the inclusion and exclusion criteria, 138 patients out of 171 were analyzed. We used the protocol of giving a depot preparation of GnRH agonist, leuprolide acetate 3.75 or 11.25 milligram in 1 or 2 doses before ovarian stimulation. Some patients had combined surgical and medical management followed by ART. Patients underwent ovarian stimulation by either a GnRH agonist long protocol using leuprolide or GnRH antagonist protocol using cetrorelix acetate injection. After suppression of ovarian function for 3 weeks after the last dose, either with the recombinant FSH or in combination with HMG, gonadotropin was started in agonist cycle. And in antagonist cycles, gonadotrophins were started on day 2 or day 3. Oocytes were retrieved transvaginally using the ultrasound guidance 34 to 36 hours after HCG injection. The number of retrieved oocytes, M2 oocytes, were recorded. ICSI was done with M2 oocytes. Fresh transfer or freeze-all of the embryos was done depending on the E2 levels, number of intermediate follicles, endometrial thickness, uterine and adenomyosis size. After conception, women attended the hospital routinely for follow-up and antenatal checkups. Complete data collection was possible for all 138 patients, and no cases were lost to follow-up. We had 2 outcomes analyzed, primary and secondary outcome. Primary outcome, we analyzed the clinical pregnancy rate, miscarriage rate, live birth rate. And secondary outcomes were cycle characteristics such as gonadotropin dose, number of metaphase oocytes, fertilization rates, and number of good quality embryos. All the data were analyzed using SPS20 software. The distribution of SEDI population based on diagnosis. Out of 138 patients, we had 38% of people having only adenomyosis and 62% having adenomyosis associated with pelvic endometriosis. And depending on the age, we had large number of population in 30 to 40 years of age group, with the majority between 35 to 40 years. Regarding the type of adenomyosis, we had higher incidence of diffuse adenomyosis compared to focal adenomyosis. So we had a population of 138 and number of patients conceived among them was 70, giving us the clinical pregnancy rate of 50.71%. Considering the distribution of ovum characteristics in pregnant patients, sorry, the previous slide, the ovum donation patients had higher clinical pregnancy rates of about 63% compared with the own egg cycles, which was 37%. Next slide, please. Modality of treatment versus pregnancy rate. Medical treatment alone has given us a good pregnancy rate of 55, whereas medical plus surgical gave us a clinical pregnancy rate of 25%. When you saw the clinical pregnancy rate, when we compared with fresh versus frozen, we had a good clinical pregnancy rate in frozen embryo transfer cycles of about 58.7 compared with the fresh embryo transfer. In the secondary outcomes, there was not much significant difference except for the dose of gonadotropins, which was more in endometriosis plus adenomyosis group, and number of M2 oocytes retrieved were more in adenomyosis group. Endometrial thickness was more or less same in both the groups. Hello? Pathology versus pregnancy rate, we didn't find any significant difference between adenomyosis alone or adenomyosis plus endometriosis group. So about the pregnancy outcome, we had 32 term deliveries and 15 preterm deliveries, giving us a live birth rate of 67.1% and had 17 miscarriages, giving us a miscarriage rate of 28.3%. So as we all know, adenomyosis have a negative impact on ART outcomes. There was a systemic review and meta-analysis by Versilini et al. Who showed a pooled relative risk of clinical pregnancy of 0.72 and pooled risk of miscarriage as 2.12. Why does this all happen? It is mainly because of the impaired receptivity and blastocyst endometrial interaction, which is due to the overexpression of aromatase P450, decrease of integrin beta-3, osteopontin, leukemia inhibiting factor, and impairment of FOXTIN gene. Next slide. GnRH agonist suppresses the hypothalamic pituitary ovarian action and gives a hypoestrogenic effect. It reduces the uterine size and relieves symptom. It also has direct anti-proliferative action. Next slide. This paper by Park et al. Has classified people into 3 groups, fresh ET without GnRH, fresh ET with GnRH, FET cycles following GnRH. He showed a clinical pregnancy rate more in FET cycles following GnRH agonist in adenomyosis patients. Next slide. Study by New et al. Has also proven FET cycles treated with downregulated with GnRH agonists had a higher clinical pregnancy rate of 51.35% compared with HRT alone. Next slide. So we had a clinical pregnancy rate of 50.71, miscarriage rate of 25.3, and a live birth rate of 67.1. Next slide, please. So a 2-stage IVF FOGSI should be considered in women with adenomyosis. First stage is OPU, a freezing of all embryos, followed by frozen embryo transfer. Prior to FET, long suppression of GnRH for 3 months or so leads to shrinkage of adenomyosis and improved implantation rate. Pre-IVF ultra long downregulation with GnRH agonist seems to give a gratifying result, thus reducing the need for surgery. Thank you.
Okay, congratulations. Presentation. But do you think the surgery is going to make a difference?
That is what our study is about, sir. We don't emphasize more on surgery, and we have got good results with the medical management of adenomyosis.
But you have not really compared. You have just got good results. It's a retrospective analysis, I agree.
Yes, sir.
You know, whether that makes any difference at all, or can we just ignore the adenomyosis and go ahead with the IVF?
Obviously, sir, it is not necessary that we should do a surgery for all the adenomyosis patients. It is very well treated with medical management, and you have got very good results of reduction in the uterine size and adenomyosis with GnRH agonists. And now there are also a lot of drugs coming up like letrozole, aromatase inhibitors, which is all showing a very promising result in decreasing the uterine size and giving us good implantation rates with the medical management of treating adenomyosis.
Yeah, but we always thought other way around.
Yes.
Medical management does not really do that much benefit, and we are also not practically seeing so much benefit, even though that is claimed, especially with aromatase inhibitors and all that, they don't touch anywhere near the
GnRH agonists. Yeah. Obviously, GnRH agonists are the best ones. Just saying the new drugs coming up.
Yeah, it is a wonderful presentation, and I have never seen so much results with the adenomyosis in my so many years of practice. Always in my mind is adenomyosis the less, but I just wanted to know about the relationship of the adenomyotic lesions and the pregnancy rates and outcome. That I did not find. Only I saw the various protocols you have done for the ovulation induction and the outcome. But really the adenomyotic lesions, how many were there, how many, they were ignored. Of course, you have not done the surgical line of treatment. You are treated them medically. But any relation of these, the presence of severity of the adenomyosis and the pregnancy rates and outcome, whether anything was studied in that line, and whether there was other risk factors when the pregnancy or live births were there, like
ma'am, there was a lot of
hypertensive disorders in pregnancy or any postpartum complications because of
we had a lot of preterm deliveries, PPROM, and we have also seen hypertensive disorders in the pregnant in adenomyosis patients because it doesn't end with embryo transfer and the clinical pregnancy rate. Live birth rate is also very, very important in adenomyosis patients. That is more challenging.
67% was the live birth rate in your case. So I just wanted to know about the additional complications these live birth these patients had.
Yeah. Madam Neelam?
Yeah. I think you have presented very well, very good, and we also follow your technique like you are doing, giving GnRH, and we reserve only excision in only very big focal adenomyosis. In those cases, we do excise. Otherwise, we don't excise the adenomyoma, and we treat with the GnRH and of course ART. And we get complication like hypertension and diabetes more in these cases, but we treat them like that. It doesn't matter, and we deliver early as soon the baby is in a viable age group.
Yes, we also do.
Dr. Aparajita, please allow me to make comments again in the positive way. Number one, you are too fast. You cannot speak that fast. Audience cannot catch because we know the subject, we know our paper, we will understand very well. You have to talk slowly so that the audience will understand.
Audience will learn. Yeah.
Number two, in this webinar era, now I can see at least 50% of the screen your face. That time, I was seeing more of a ceiling fan. Your forehead was seen. Okay. These are the two additional comments just for the better presentation. Next.
Okay, sir. Thank you, sir.
But it was very nice.
Thank you.
Very nice. Congratulations, Aparajita. Very nice presentation.
Thank you.
Thank you, Dr. Aparajita. And now let me have the pleasure of calling Dr. Shivani for her presentation. Dr. Shivani here? Dr. Shivani, are you here? Dr. Shivani? Can I, or we can call Dr. Vinodini and then we can have Shivani. Dr. Vinodini, are you here?
No.
Yeah, let's start with Vinodini and after that we will have Shivani. Dr. Priyankur, do you have Shivani's number? For
Yeah,
some...
I will call.
Yeah, now we'll start with Dr. Vinodini. Vinodini, please, yeah.
Can you see my screen?
Yes, we can see it, yeah.
Good evening all. I'm Dr. Vinodini. I'm a postdoctoral fellow in endogynecology at Ramani Coimbatore. My paper is on fertility outcomes following laparoscopic surgical management of endometriosis in infertile women and determining the role of endometriosis fertility in an Indian cohort.
Put it on slideshow, please. Can you maximize the slide? From bottom.
It's bottom right-hand corner.
Dr. Vinodini, you also have it there. You have clicked correct from beginning, left-hand side, first one.
Okay. Yeah, on the top. Yeah, that one.
Yeah, that one. Yeah.
As we all know, endometriosis is an inflammatory condition characterized by lesions of endometrial tissue outside the uterus, and the primary presenting symptom of endometriosis are infertility and or pain. Among infertile women, 25 to 50% are thought to have endometriosis, and 30 to 50% of women with endometriosis are infertile. Improvement of fertility ability in women with endometriosis has been investigated by various medical and surgical methods or combination of both. Surgical resection of endometriosis is a standard treatment of choice in symptomatic women desiring pregnancy. Since currently most frequently used staging system for endometriosis is the revised American Society classification of endometriosis. Unfortunately, this classification system cannot predict the clinical outcomes of treatment effectively, especially the pregnancy rates. And hence, in 2010, Adamson and Pasta proposed the Endometriosis Fertility Index, The EFI staging system includes historical factors and surgical factors, which include all the AFS scores, AFS total endometriosis score, and the least function score as an anatomical and functional result of the surgery on the reproductive fallopian tubes, fimbriae, and ovaries bilaterally. Endometriosis fertility index has been proposed and validated tool in predicting the spontaneous pregnancy rates in these women. Various studies reported increased pregnancy rates after the surgical resection of endometriosis, studying various parameters, EFI being one of them. To our knowledge, till date, there is no Indian data on the validity of EFI on fertility outcomes after laparoscopic surgical management of endometriosis. This study is to assess the validity of EFI in predicting spontaneous pregnancy rates and cumulative pregnancy rates in an Indian cohort. The primary objective of the study is to assess the validity of EFI in predicting spontaneous pregnancy rate, as well as the validity in predicting cumulative pregnancy rates in the Indian cohort. And the secondary objective is to determine the components of EFI which are significant in affecting the pregnancy outcomes. And it is a retrospective cohort study done in a private hospital, Rao Hospital, Coimbatore. This retrospective study enrolled infertile women with proven endometriosis seeking treatment for infertility from 2017 till early 2020. They all underwent surgical resection of endometriosis by a single skilled surgeon specializing in laparoscopic surgery for deep infiltrative endometriosis. This is the inclusion and exclusion criteria. And these were the clinical parameters which were collected. Among 57 patients were enrolled for the study, and 3 of them were excluded as they lost follow-up or the outcomes could not be traced. And another 4 were also excluded as they had other associated causes of infertility, which are 2 male factors and 2 adenomyosis. And hence 50 patients were taken eligible for the study. And this is the chart for calculating the EFI, and the scores were calculated. The statistical analysis was done using SPSS 2.0 and categorical variables expressed using frequency and percentage, and numerical variables presented using mean and standard deviation. Kaplan-Meier survival analysis was used to calculate the cumulative proportion of spontaneous pregnancy rates according to the different EFI scores, and the cumulative pregnancy rates after surgery and ART. The log rank test and the Cox model was adopted to assess independent predictive factors for pregnancy. Comparisons were performed using chi-square test and independent t-test. A p-value of less than 0.05 was considered statistically significant. Hence, moving on to the results of the 50 patients included in the study, the average age was in the range 21 to 39 years, and primary and secondary infertility in the cohort is 38 and 12 respectively. And the mean AFC was 6.67, and the mean AMH value was 2.99. The average EFI scores of 50 patients was 7.06, the most common being 8, where 14 patients had an EFI score of 8. Out of the 50 patients, 21 patients opted to wait for spontaneous pregnancy, and the remaining 29 opted to go directly ahead with ART. 60% patients, that is 30 patients, had positive fertility outcome, of which 10 had spontaneous pregnancy and 20 were ART. In the spontaneous group, 10 out of 21 and 20 out of 29 in the ART group had successful pregnancy during this period. The average time between the surgery and the spontaneous pregnancy is 8.2 months. The median EFI score in spontaneous pregnancy, ART, and infertile women were 8, 6, and 7 respectively. This is the life table analysis, which shows a significant relation between EFI and fertility outcome, but it is underpowered. Patients with high EFI scores had high cumulative pregnancy rates compared with patients with low EFI scores. Among all the components, LFS correlates more to the spontaneous pregnancy rates. And going on to the discussion, currently main choice of diagnosis and treatment of endometriosis is a laparoscopy. For infertile women with endometriosis as the only identifiable infertility factor, operative laparoscopy can improve pregnancy rates. In our study, the possibility of spontaneous conception was 47% after surgery, which is better than in untreated patients. In patients undergoing ART followed by surgery, the pregnancy rate was 60%. Various studies report a pregnancy rate of more than 50% after surgery for endometriosis and ART. Our data also concurs with the same. Thus, EFI helps in predicting the spontaneous pregnancy rate in a given patient, thereby counseling them regarding further treatment options. In our analysis, there is a relative agreement between the EFI and a spontaneous pregnancy, but it is inadequately powered because of a very small sample size. In our study, IV was offered to patients with prolonged infertility and low EFI scores, which was a shared decision making. All the patients opting for IVF after endometriosis surgery were put on long down-regulation protocol and underwent embryo transfer at approx 3 months after the surgery. Thus, the time for pregnancy after surgery in the IVF group could not be assessed. Our study shows the cumulative pregnancy rates with high EFI are better than those with low EFI, but again, this is statistically not very significant. Although a lot of progresses on endometriosis have been made in recent studies, the molecular mechanisms underlying the endometriosis are still not completely understood. Laparoscopy can improve the fertility by removing adhesions, cul-de-sac obliteration, and endometriosis. Coming to the conclusion, the EFI is a reliable staging system to predict spontaneous pregnancy rates in Indian women also. The robust evidence from a study is lacking. High EFI also indicate high cumulative fertility rates, but this is statistically not significant. Least function score was the most influential factor to predict the spontaneous pregnancy rate among components of EFI in Indian women. Thank you.
Judges, please note she finished in 6 minutes, 35 seconds.
Landing. Yes. I'm really not an infertility person, but really the presentation looks very nice. I just wanted to know whether we can improve this EFI score in any way.
Ma'am, the EFI scores are made during helps us in assessing and the prognosis of the patient and the future fertility outcomes, and helps us in counseling the patient regarding how her fertility outcomes would be.
So how can you convert this study? You said one of the limitations is it's retrospective. Suppose they ask you to design a prospective study, how would you design it?
Design, yeah.
How would you convert this?
I will randomize the people into 2 groups and then do a study.
What is that? What are the groups? You have to come out with the study plan. See, madam has guided you nicely to analyze and all that. Now you are the person who has to take forward the research and the studies. So just tell me in one minute, how do you plan this? To overcome this limitation of what you said. Otherwise, it was a very good analysis and everything.
One group I will out of 2 groups, one group I will randomize into based on the EFI scores. I'll randomize one group into I'll randomize into 2 groups, sir.
Tell me, spell out correctly. What are the 2 groups and how will you proceed?
Based on the one group will be the outcomes for the spontaneous pregnancy rate.
Because you are a future researcher and you are a future guide, right? Okay, all right, doesn't matter. Anybody else? Dr. Neelam?
Yeah, she can 2 groups, like one group having a EFI study with it and one without that, and compare how to go. But even I prefer laparoscopy in all the infertile patient where do we suspect endometriosis after 2 years of married life. It is always better because beside endometriosis, we treat also so many things, the adhesions and all, and usually outcome is very good. So I think laparoscopy, even mini laparoscopy can be done with a small scope with 3 mm, and that is very beneficial, and small things can be done with that also. So laparoscopy is always beneficial, and I'm totally agree with her.
Yeah.
Asha ma'am?
Yeah, I think, yes, we had very nice discussions. It was very good moderation. Thank you.
Dr. Shivani?
Bye.
What about Shivani?
Oh, yes.
Dr. Shivani,
No.
but she's not taking the phone. I think she will not be presenting, sir.
Okay.
So we'll move on to the posters after ma'am
So
concludes.
Dr. Vidya Tobi, Dr. Neelam Mishra, and Dr. Pai, Thank you so much for the wonderful discussions and taking your time off from a very busy schedule. You made it so.
For you, we are always free. Anytime you can call me. Now my daughter marriage is over, so I am totally free. I was very busy till 25th. Now everything is over.
Thank you, Neelam. So you can talk to each other and finalize the.
No, actually, we have marked it and we are handing over to Priyankur.
Okay.
So he will totally talk.
Yes. Now we are. Yep.
Individually, we have marked.
So now, Asha ma'am, I'll take over for the poster.
Yes, please. Yeah.
We have to judge that too, right?
Yes. So the suggestion is that we give 2 minutes to the Priyankur will tell us. Yeah.
So it gives me pleasure. Now we have come to the end of the paper presentation. Excellent papers. So we move on with the posters, and I again would like to thank Neelam ma'am, Muralidhar sir, and Vidya ma'am for spending time on today's evening. So for the posters, we have shortlisted 4 posters. So for the posters, we had initially decided that we will just display the poster and the questions will be asked by the judges. 1 minute each judge, and then we mark them according to that. But now for the benefit of the participants, we have a lot of participants here. The fonts are very small on the posters and they might not be able to read it. So we will just allow the participant to say two minutes of details about the poster, and then we will move on to the question answer so that everyone understands what is happening.
Sure.
So each person only 5 minutes, 2 minutes of talking by the candidate and 3 minutes by the judges.
Correct.
And I would also, before we move on to the poster, would like to thank actually Dr. Abhinaya. She is the one with Dr. Ramani Devi. So she has excellently prepared the background for the PowerPoint presentations, and it looked very uniform and nice.
Hello of endometriosis.
The endometriosis outlook to the conference, that it was looking so nice, and the endometriosis thing was coming into it. So thank you, Abhinaya, for that. So now,
Abhinaya.
Yeah. So now
the first candidate is.
The first candidate is Dr. Geeta Raj, and she'll be presenting on recurrent endometriosis and an unusual presentation. So over to you, Dr. Geeta. You'll have 2 minutes to describe your poster, and then the judges will ask you questions based on that, and you have to defend it. Thank you.
Good evening, everyone. Am I audible?
Yes, you are.
Yeah, I'm Dr. Geeta. I'm a senior consultant at Rao Hospital, Coimbatore in Asha ma'am's team. My poster is about an unusual presentation of recurrent endometriosis with hemorrhagic ascites. This lady presented to us in March 2020 with an unknown diagnosis of recurrent ascites for past 1.5 years. That she had undergone, she's a 31-year-old with the primary infertility, and she had undergone laparoscopic surgery by a non-gynae laparoscopic surgeon in 2018 for endometriosis. She has undergone a bilateral endometriotic cystectomy and removal of a subserous fibroid and adhesiolysis. After that, she has had, she was just left alone, like to try naturally. In 2018, she is presented there with the ascites in the same hospital, and they've done a CT, and all they found out was the ascites with clumped small bowel, and they've made a diagnosis of pseudomyxoma peritoni, and they have done an ascitic fluid analysis, which we are not, tumor markers were negative. The ascitic fluid analysis has come as query pseudomyxoma peritoni. After that, they've done a cycle of IUI and it failed. And all these days, she was totally asymptomatic. There were no clinical features of endometriosis. Again, in 2019, she had repeat CT, which showed ascitic fluid reaccumulation, and they've given empiric antituberculous treatment for 6 months. Even after that, she had similar findings in the CT. They've been following up with the CT and no other treatment. She didn't have any loss of weight or loss of appetite. All her tumor markers were negative. And when she was referred to us, like we planned a exploratory laparoscopy, but because of the dense adhesions, it was converted to open laparoscopy. All we found was dark brown ascitic fluid. There were adhesions everywhere, and the small bowel and omental adhesions, and there were insisted fluid collections and unhealthy serosal surface of the tubes, and everywhere there were adhesions. And all loculations were aspirated, and the biopsies were taken from the omentum and the peritoneum, and the endometrium also was sampled to rule out tuberculosis. She had good post-op recovery, and when we did the histopathology, like we didn't have a clue about what it is. We were suspecting some kind of endometriosis recurrence or maybe something else. So when the histopathology report came, it was reported as xanthogranulomatous salpingitis, and which may be secondary to endometriosis. Otherwise, the uterus and the ovaries didn't have any sign of endometriosis. The biopsy which was taken from the tube, the unhealthy serosal surface of the tube, showed that xanthogranulomatous salpingitis, which is characterized by this picture, like the tubal plique is distended with the lipid laden histocytes, which is a classic sign of pseudoxanthoma of the fallopian tubes. And because it is a advanced disease and the histopathology has come as endometriosis, we've counseled her to undergo IVF with the downregulated protocol. She had received 4 doses, but because of the COVID pandemic, she was called, we could review her only after 7 weeks post Lupride, and she had an uneventful stimulation, the egg pickup, and during the stimulation there was no accumulation of fluid, because all the fluid, it was all suppressed with the agonist treatment. And she had 11 oocytes, and out of that 6 embryos were frozen. We didn't do a fresh transfer because of high E2 levels and increased risk of ovarian hyperstimulation. Luteolysis was given with the luteal antag and regestrone, and we planned for a downregulated FET. But unfortunately, when she came back with the day 2 period, she had reaccumulation of the fluid. Almost all the compartments more than 1000 ml. Then again, because she had a documented evidence of the fluid, she had documented evidence of agonists acting. We planned a Lupride depot waiting for the fluid to get absorbed on its own. But 3 weeks later, she again presented with the same amount of fluid almost. There was only a mild reduction. So we planned for a transvaginal aspiration. Basically, we planned it because the abdomen was studded with adhesions, and the transvaginal route was easy because it was from the dependent portion. About 850 ml was removed, the same hemorrhagic brownish yellow fluid. And after that, we suppressed her again with analogs. Now there is no reaccumulation of fluid. This case, I'm basically presenting to just create an awareness that this presentation is very unusual. And because of the unawareness of this condition, like there was an delay in initiating the treatment for her. Almost 2 years were wasted on finding out the diagnosis. And we should also counsel that reaccumulation is possible even with the prolonged suppression, even during pregnancy. Counseling plays a very important role in such cases.
Yeah. So thank you, ma'am. It was really a rare case. But can you actually tell us why there is so much of secretion in endometriosis? Is it just because of that, or it's incidental?
Sir, actually, there are no proven theories for what is the reason for ascites.
Yeah.
But there are few papers which say that it may be because of the peritoneal irritation, the endometrial stromal cells causing peritoneal irritation. That could be the reason for this accumulation of.
It happens only in such rarity. So that's why there may be an additional factor in this particular lady or this particular types of ladies. Because so many people have endometriosis, we don't see so much of secretion. There is definitely irritation and there is definitely secretion, but not so much. And the sad part is that it is not getting suppressed. Even though you said the diagnosis was delayed, but even after the diagnosis, nothing much we can really offer. That's what you said, that no real suppression with the known drugs.
Sir, once we diagnosed, we actually started the treatment as such, because basically she presented with infertility. So we've done an IVF, and now with analogs.
IVF part is all right. That is correct. But I'm talking about this getting rid of this secretion and solution.
She may require multiple doses of gonadotropin analogs, gonadotropin releasing hormone analogs. With the analogs, there is actually no reaccumulation. When we saw her on 16
we
level,
can't be giving her more than 5 to 6 injections, and because that itself will push her into so many other problems,
yes,
type of problems. So it doesn't respond to progesterones at all.
So we have not tried progesterones. There are a few papers which say that progesterones also help, and there is some paper which says that
Because that's the only thing we can give on a long-term basis.
Dynogest helps. There is one article in JMIG which says that Dynogest can help. Again, by giving Dynogest, we are only like the embryo transfer could be postponed. So time delay is there in achieving pregnancy.
Yeah.
We may need a prolonged suppression.
Yeah.
Sure.
Very good case.
Thank
Very
you,
good case, very good presentation. And this can happen when the endometriosis is more on the subserosal surface in the peritoneal, more of peritoneal origin, then these ascites can occur. But this even we are seeing for the first time reaccumulation and all. It's a very rare case.
Around the world, only 60 to 70 cases are reported. And somebody has done a review of the entire cases, like about 63 cases, that is published in 2011 in Archives of Gynecology and Obstetrics. And they say it is more common in African Black women, and 80% of them present with infertility, and 30% could be associated with pleural effusion also. But fortunately, in our case, like she didn't have pleural effusion. But now that the fluid is not reaccumulating, we have started endometrial preparation. Last week we have started endometrial preparation, and we are expecting the transfer in the next 10 days.
Have you ever seen CA125 estimation when there's increasing, or again it is? Have you got it done? No, never.
Yes, ma'am. This patient, it was done repeatedly, and all the times it was either normal or it was mildly elevated.
Very
good presentation. I think all is discussed. So
very good.
Yeah.
Thank you, ma'am.
Thank you, Dr. Geeta. That was a wonderful presentation. So now moving on, I would next like to request Dr. Gurpreet Kaur Sandhu to kindly present your case. I kindly request you to finish your presentation within a couple of minutes so that the judges can ask you questions, and then
we are not able to see actually the whole poster clearly.
Yes, ma'am. That is why we have requested the candidate to present her case.
Yeah. And if you could have mailed us, no, we could have done it better.
We can put on the laptop, in your laptop, another this computer you can see. At the same
no, madam. This is only one which is available with me right now. Should I go ahead?
Yes, Dr. Gurpreet, you can go ahead.
Yeah, thank you so much for giving me the opportunity. And this is one case I'm presenting today. This is now with the introduction, endometriosis is a common gynecological disease found in women of reproductive age, the natural history of which is poorly understood. The prevalence range is between 2 to 22%. The gold standard is always laparoscopy. The Cochrane collaboration and the Royal College of Obstetricians and Gynecologists also suggest that surgery is a first-line treatment for infertility and endometriomas, only with the little mention of pain. Laparoscopic removal of endometriosis has been labeled as a last resort procedure to be contemplated when all medical options have failed. So this case, patient came with complaint of primary infertility since 4 years. She is, her age is 31 years, constantly complaining of pain in abdomen during menstruation, which was sharp and stabbing in nature. Pain was not relieved by any medication whatsoever was given to her, radiating from lower abdomen into the flanks. There was difficulty in defecation. The triple triad, that is dysmenorrhea, dysplasia, and dyspareunia, were all seen in this patient. Menstrual history 8 days back, her previous menstrual cycles were irregular, 6 to 7 days.
We don't want such details. What actually happened, you tell us.
Yeah, so we posted the patient for laparoscopy. She was a case of primary infertility since 4 years. Uterus was normal, and both ostia were seen, and the cavity was good. On operative laparoscopy, uterus was adherent to the right ovarian cyst and the POD. So adhesiolisis was done, evidence of right ovarian endometriotic cyst or two cysts of 3.3 and around 3.4 centimeters. Cystectomy was done. So evidence of rectovaginal endometriosis, that is deep infiltrating endometriosis, was there in this patient, and specimen was removed in the endobag. The conclusion what we draw from this case is endometriosis cyst may damage the ovarian reserve prior to surgery. Given an increasing incidence, we are emphasizing here that rather than waiting, for natural pregnancy to occur, it is always better for the diagnosis and the for the management in cases of infertile patients to actually go in and do the cyst wall removal,
okay,
and then put the patient on stimulation protocol. That is what I wanted to emphasize through my
what
case.
is the title of your study, ma'am?
This is what the conclusion is, sir.
No, title. I can't read the title of the study.
This was an interesting case of right ovarian endometrioma, which was.
What is so interesting about it?
So initially, when the patient presented to us, the size was very small and around 3 centimeters. But we, when we waited for 1 more year, one more cyst had developed, and then the pain, the dysmenorrhea, it kept on progressing. So that is the reason why we have presented this case, and it. Though on the investigation, it showed out to be less in dimensions. While operating, it was a huge cyst that we had operated on. Rather than medical management, we should actually put in a scope and go in for the further management rather than wasting time, and that's what we wanted to send a message through this presentation.
Vidya ma'am, you want to ask something? I think Dr. Paisa's net is stuck.
Hello.
Yeah. I can hear you. Dr. Neelam or Dr. Vidya ma'am, do you want to ask her something? Dr. Paisa's net is stuck, I guess.
Yeah, I think they should be, if endometrioma is small, we should not go for surgical treatment, and if they are large, then only we should, before after doing AMH, we can go for surgical treatment. And nowadays there are more devices are coming, like just drain the endometrioma and put some alcohol in the waste, so that it simply we don't damage the ovarian tissue. So that way we can preserve the ovarian tissue. And your presentation is very nice, but you tell what are the at 3 centimeter cyst endometrioma you want to do surgery, or you can wait to go for some stimulation and then do surgery.
Madam, as it is, endometriosis is a progressive disease. The more we wait, the more damage it is going to cause. And it is always, I feel it is better to, there are studies being done, but there is, they haven't come to any conclusion that, keeping it or just removing it out is going to change the protocol. In fact, with the age, she is already 31. It is going to also affect her AMH levels later on if we still wait for the patient for natural conception.
But for small endometrioma, they don't, they reserve surgery for larger endometriomas, not for small endometrioma. First they stimulate, and if patient conceives, it's better always. You should try 1 or 2, 3 cycles, then only you can think of proceeding for the surgery, isn't it?
Right.
What about others? I don't know. Dr. Priyankur, what is your opinion for small endometrioma?
For small endometrium, I do not obviously go for a surgery as the first
try
for medical management, because now Dynogest has come as a wonderful drug. So sometimes we can try medical management.
Conservative treatment.
Surgical.
But medical management, she has already tried, madam. Means she has already taken many medications, including Dynogest and other NSAIDs. Her pain was so much that even the anatomy was distorted on laparoscopy. Then it was very much close to the ureter. That was again one point that is to be mentioned. And
how many years married life she had?
4 years, man.
4 years married life.
And her age is 31 years.
Okay, then okay.
Yeah.
Thank you, Dr. Neelam. Thank you, Dr. Gurpreet. Wonderful presentation.
Thank you.
And,
thank you.
Yeah. So now moving on, I would like to now invite the next presenter, Dr. Sukanya L. And she'll be presenting on a bizarre surgical aftermath treated with excision and mesh plasty. So over to you, Dr. Sukanya. So you get a couple of minutes to present your case, and then the judges will ask you questions.
Sure, sir. I'm Dr. Sukanya, senior resident from Savita Medical College, Chennai. I'm going to present a bizarre surgical aftermath treated with the excision and mesh plasty, which is nothing but the scar endometriosis. My patient is a 32 years multiparous lady with a history of 2 cesarean section, which was done in 2012 and 15. And along with the cesarean section, second section, PPICD was inserted. And she was asymptomatic 4 years after the second cesarean section. So last 1 year, in 2019, in October, she started developing swelling in the scar site, in the phenestrel scar site, where she noticed that there was a discharge from the swelling during the menstrual cycle, particularly on the day 3 of the menses, which was lasted for 5 days associated with the pain. And she was given NSAIDs and oral progesterone therapy for 6 months from the local hospital. After 6 months, with all these complaints, she did not take any tablets because her symptoms persisted in spite of the progesterone therapy. So she had come to us, and we have noticed 6 cross 4 centimeter hyperpigmented, hard indurated mass in the right side of the scar, and with the 2 mm of orifice. On pressing the mass, we saw that chocolate brown fluid was oozing from that. So with the diagnosis of scar endometriosis, we have taken her for the surgery. We have done wide excision of the scar endometriotic tissue with mesh plasty. Intraoperatively, we have found that the scar endometriosis, which was lasting from the skin, subcutaneous tissue, rectus sheath and rectus muscle was involved with the peritoneal layer. It was attached to the anterior surface of the uterus, but there was no communication with the cavity. So we have done a wide local excision. After the wide local excision, we had done a mesh plasty, mesh repair with the sublay mesh fixation with a polypropylene mesh, 15 cross 15 centimeter. And after that, we have done a onlay mesh repair, and we had closed with the drain in situ. After 14 days post-operative, we have removed the drain, and suture was removed on day 15. And histopathology diagnosis of scar endometriosis was made. The discussion is mainly this in the present index patient. It is mainly due to the mechanical implantation because of the history of cesarean scar. And the main mode of diagnosis is histopathological diagnosis, and treatment is wide local excision.
It was excellent management. This picture is yours, that the tummy picture you are showing?
Yes, sir. Yes, sir. That was taken in the intraoperative after anesthesia.
Not intraoperative, the left one.
Yes, sir.
Figure A. Figure.
Yes, sir. Yes, sir. Our picture, sir. That is our picture. The index case only.
Okay. Okay. The next. Okay. So, what do you think is the chance of recurrence after this wide excision?
If we do the wide excision, the recurrence rate is very, very low. But if the excision, while doing the excision, if any remnants or any tissue is retained, patient might present with a recurrent.
Do you think we need to give any medication for suppression?
Actually, if you do a wide excision, there is no need to give. But in the present patient, we have started her on progesterone, sir.
Okay.
Oral progesterone has been started. At present, patient is under follow-up.
What is the reason of this scar endometriosis?
This is because of the previous cesarean section.
I know, but we do thousands of cesareans. Nobody will get this.
So the main theory behind this was a direct mechanical implantation of the endometrial tissue in the layers. So when we do the cesarean section, most of the people have a habit of cleaning the endometrial cavity. They put a mop inside and clean the endometrial cavity. With the same mop they use in the peritoneal layers and rectus sheath and all.
Not
And,
only from the point of causing endometriosis, even that cleaning with the mop, the endometrium can be damaged.
yes, yes, sir.
Should be avoided.
And suturing techniques also. They use the same catgut which they use for suturing the uterus. They close the peritoneum and the rectus muscle also they close. And subcutaneous, I have seen subcutaneous tissue also they used to close with the same catgut.
Do you still use catgut?
Sorry, sir?
Do you use catgut?
For what, sir?
You said suturing catgut, you said.
Yes, sir.
Are you still using catgut?
Vicryl and catgut. Both.
Is it?
Yes, sir.
What complication this mesh can have?
Sorry, ma'am. What
Complications of mesh.
Complications of mesh is post-operatively she can have mesh infection. There will be a seroma formation, a hematoma formation might be there, and the mesh may get displaced, mesh displacement, and hernia can also happen.
If not properly placed.
If not properly placed, hernia can also happen from the incision site.
Yes. Why not GnRH or Dynagest for follow-up? Why progesterone only?
GnRH also we can give ma'am. Anyway, she is family completed a patient. Anyway, she's not planning for future fertility.
Then after putting mesh, it is very difficult to operate her again.
Yes, ma'am.
Yeah. I've seen one case like this endometriosis in the episiotomy, and it was very difficult. We have to do very deep excision, and the same thing. Then I gave her on I put her on GnRH even after the excision, wide excision, and after that she was alright. It can happen in the episiotomy also.
Yes, ma'am. We also had a case.
People they clean uterus with the gauze and all post delivery. One should not do.
Yes, ma'am.
Thank you, Dr. Sukanya. It was a wonderful presentation. So
Very
now
good. And very good pictures also.
Last presentation of this session, the paper and poster presentation competition. It is by Dr. Taraka Sendhi Raja. So she will be, Dr. Deepika, can I have the next slide, please? Dr. Deepika, can I have the next slide, please?
It's there, sir.
Yeah.
Oh,
The red color slide.
yeah. Yeah, so it's on endometriosis, a disease with no boundaries, a case report on sigmoid colon associated, sigmoid injury associated with endometriosis surgery. So I request Dr. Taraka to take over and present her poster before the judges ask you questions. Thank you.
Am I audible, sir?
Yeah, you're audible, Dr. Taraka. Please go on.
Yeah. Good evening. I'm Dr. Taraka, senior resident from Savita Medical College and Hospital, which is in Chennai. So I'm moving on to my case. My patient, who's a 38-year-old para-2 living to female, who presented to us with complaints of pain abdomen, basically severe dysmenorrhea for the last 3 months. Patient also gave history of some surgery, open surgery, which she underwent 2 years ago in a different hospital. We couldn't review all her reports because she did not have a discharge summary, but we found a review case sheet in which it was written that they had done a left ovarian cystectomy, and it was reported to be serious. Shall I continue, ma'am?
You can continue.
Yeah, please continue.
Please continue.
Yes, we got a report like where it was mentioned that she underwent a left ovarian cystectomy, and it was reported that the histopathological report showed that it was a serous cystadenofibroma. So this patient presented to us 3 months ago with complaints of pain abdomen. We further evaluated her on examination. On general examination, she was fairly normal. On per abdomen examination, except for the previous surgical scar, there were no other findings. On per speculum examination, she had her cervix deviated to left side. but it was healthy and vagina was healthy and there was no discharge or bleeding. On per vaginal examination, the cervix was deviated to left side and it was firm in consistency, and uterus was 12-week size and deviated to left side with a cystic mass. There was also restricted mobility and both the fornices were felt full and it was tender. So we further evaluated her and we got our investigations also done. We got an ultrasound as well as a contrast enhanced MRI done, both of which showed a 9 cross 8 centimeter left adnexal cyst and a small fibroid in the anterior myometrial wall. And also there were features of adenomyosis. So we got tumor markers also done. CA125 was 257 milli international units. So so further we planned the patient for surgery. Because of the inconclusive nature of the cyst, we planned for a staging laparotomy. So on the day of surgery, we opened up the patient after taking consent and all. We did an exploratory laparotomy. We did a peritoneal wash cytology, and on intraoperatively, we found that the uterus was around 12-week size. There was a 5 by 3 centimeter subserosal fibroid and on the anterior fundal fibroid, and also there were like dense adhesions between the uterus and bilateral ovaries with the sigmoid colon. So we also noted on the right ovary, which was mentioned normal on the MRI finding, we saw it was around 3 by 3 centimeter. It was bulky with multiple endometriotic spots all over the ovaries, as well as there was 9 cross 8 centimeter left ovarian cyst, and while operating itself, it was ruptured intraoperatively and there was chocolate fluid. So we had pre-operatively, we had asked for surgeon's assistance in view of dense adhesion. So while we were proceeding with hysterectomy, we noticed a 3 centimeter sigmoid rent, which was repaired primarily by the surgeon himself. So post-operatively, intraoperatively, we had also put an abdominal drain for monitoring the patient. Post-operative management was very critical in this patient since she had a sigmoid colon injury. So we had kept the patient nil per oral for 5 days, and because since the patient was on nil per oral, surgeons had also started her on total parenteral nutrition. She received TPN for almost 3 days, and because of TPN, we had to closely watch her for metabolic abnormalities. Thankfully, she did not go into any metabolic abnormality. So slowly, we started her orally. Initially, she passed flatus on post-op day 3, and she defecated on post-op day 5. So after she defecated, abdominal drain was successfully removed, and the patient was discharged eventually. So going on to the discussion, we all know that the endometriosis surgery is associated with lots of complications, especially bowel injuries and bladder injuries, because of adhesions. The conclusion which I want to make is that even though bowel injuries are very common, we should do a meticulous planning with a multidisciplinary approach so that we can give a proper care and deliver optimal care to such patients. So post-operatively, we are planning to start this patient on menopausal hormonal therapy also, because we have done a total abdominal hysterectomy as well as bilateral salpingo-oophorectomy for this patient. Since this patient is only 38 years old, we are planning to start her on menopausal hormonal therapy also. Thank you, sir.
Okay, good presentation and good management also. But do you think sometimes we cannot avoid at all sometimes the injuries? So suppose you, yeah?
Yes, sir. It is very common. It is mostly associated with endometriosis surgery, sir. It's almost 65% of
should
chances
we
of
repair
injury.
or should we call the surgeons always?
Sir, if it is serosal repair, we can try repairing, sir. But for better outcome, it is always better to involve a multidisciplinary team.
Yeah, it depends upon where you have operated. If you are in a tertiary care center, it is always better to call the surgeons, otherwise you will be sued for that. Only in a place where you don't have the surgeons, then you can try serosal closure or whatever it is. But if it is a bigger injury, as you correctly said, we have to manage it properly. And in such cases, we must take consent beforehand for a colostomy as well.
Yes, sir. We had taken colostomy consent also, sir.
I'm sure. I'm sure. If there are no other comments, Dr. Neelam?
Yeah, when we know we are going to operate stage 4 endometriosis, we must take proper consent key, like anything, any injury to ureter or bladder or bowel can happen, and then we will involve the respective surgeon. We should take consent from the patient. You are very right. And this can be saved to somehow if we do I don't know what she has done. If the proper dissection is done, including the posterior uterine wall. So, because we have come across so many cases after putting vasopressin, we do the adhesiolysis of the bowel with very thin layer of the uterus also. So this will not happen, rent will not happen, and then you push downwards. But it's okay, she has done very well and happen with anybody.
The entire posterior wall was adherent with the sigmoid, ma'am, along with the left and axil mass also. So it was unavoidable.
You used vasopressin that time?
No, ma'am, we did not use, ma'am.
If you use now, so dissection becomes very easy.
Okay,
Even with the open surgery.
Yes,
if you dilute it in 200 and use it, it becomes very easy.
Okay, ma'am.
Yeah.
We'll involve that.
Yeah, it was an excellent poster, and she has put the pictures rightly.
Yeah.
And as Dr. Muralidhar was telling that it is a multidisciplinary approach always, and the medical legal issues also we should always have a look into. So, thank you very much.
Dr. Taraka, please allow me to make one comment on your post.
Yes, sir.
You should not use red background.
Okay, sir.
Red background is always to be
avoided.
avoided.
Background is red. Yes.
It is very imposing, and it is very jarring to the eyes. You must use always the lighter color for a better impression. I want you to do better in this post.
Yes, sir. Sure, sir. I'll improve, sir.
Please don't mind.
Please go through Dr.
No, sir.
Murali's
Thank you,
presentation, how to present yourself. He has a very good presentation on that.
Very good
I'm
presentation.
sorry, because when I see this, I want everybody to do better.
Dr. Muralidhar is very good.
No. Not the question. I want to please everybody to have a better presentation. That's why I comment. So I hope.
Take home message from all of us.
One more thing, Dr. Muralidhar, after doing any bowel anastomosis, one must do Lord's procedure.
Correct.
So it is very good. One must do Lord's procedure, so there will be less chances of
injury. Yes.
Yeah.
Okay, thank you everybody for inviting us as the judges, and Dr. Priyankur especially, you took a lot of care to arrange all these things. Dr. Asha Rao always invites me in one or the other form as a speaker or as a judge or as a panelist, and Dr. Ramani Devi for excellently organizing this. Thank you, everyone.
Thank you so much.
Thank you everyone.
Thanks to Murali, Dr. Vidya and Dr. Neelam for having honored us by being judges for this poster and paper presentation. Thank you.
It gives me I really like to thank the judges from the bottom of my heart, Dr. Neelam, they have given almost 3 hours of their valuable time today in the evening and judge these papers. I would also like to thank all the participants who have presented their papers today, be it paper or poster. And also, I would also like to thank all the viewers who are there with us. I would thank my coordinators, Dr. Subash, Mallya, Asha Rao ma'am, and Ramani ma'am and Kanthi ma'am for giving the opportunity. And I would request now Asha ma'am to give the concluding remarks and hand over the session for the video presentation. Over to you, Asha ma'am. Thank you so much.
Kanthi Bansal ma'am.
It was really a wonderful session.
Now the way you're asking questions to the presenters, oh my God, it's such a learning session, especially with a professor like you. Thank you for that.
Hi, Dr. Ashish.
It was really a wonderful afternoon. Dr. Pai, Dr. Vidya, and Dr. Neelam. I have enjoyed this more than anybody. I'm sure the delegates and the participants also are extremely benefited. So thank you all for spending your valuable time and your expertise. Thank you so much.
Dr. Deepika, you conducted this very well. Congratulations.
Nice to see you, sir.
And thank you, and we also learned many things from these papers and posters. Very Thank
So
you
I
very
will
much.
send this Dr. Priyankur by email right away.
Yeah,
Yeah.
really. Yes. Thank you.
So, dear friends, we move on. Such exciting sessions have been going on from the afternoon, right from 3 o'clock till it's already 6:30, but I don't know how the time passed. Such excellent, PG students who were very good at the quiz, who were very good at paper presentations, and also the poster presentations, and of course essays. Now much more exciting, the real practical portion what we do in our clinical practice, and that is the video session. And for this, I would like to invite Dr. Malaraj, Dr. Vidya Bhatt, and Dr. Ashish Kale. So here is Dr. Malaraj. She is a female laparoscopy and infertility specialist. I feel very proud when I introduce female laparoscopy. Yeah, really. And she's managing director of Firm Hospitals, and she's doing very good work every time. Whenever we've had any meeting of endometriosis, she's always in her OT dress, telling us how busy she is. That's really awesome. And another very good point is she's very mild. I think she's a very mild girl and too beautiful to see. Really. So welcome, Dr. Mala. Now I would like to introduce Dr. Vidya Bhatt. Can I have her? Yeah, one more favorite of mine, Dr. Vidya. Favorite because she has everything what a lady should have, including she's very intelligent, bright, and so good at laparoscopy. I've seen her operating from so many years now. And the best part about Vidya is that she tells the truth. And once I was so delighted to see that Vidya was talking on what complications she did in her center. I think for that you need to be very bold, straightforward, and you have to have guts, and that also shows that you're a very good laparoscopic surgeon. So she is the medical director of Radhakrishna Multi-Speciality and IVF Center, Bangalore. I'm very closely associated with this center, especially when it is concerned to IVF. From the scratch we had worked for it, and now she's doing so many cases, and she has conducted many live demonstrations and workshops, etc. Been invited to many international and national conferences. She's been the president of Karnataka Society of OBGYN, Secretary General of they call it Kasoga, and president of Bangalore Society as well, and so many other things. And she's also been awarded with several awards, and trained in international students from Nepal, UAE, Maldives, Nigeria, Sri Lanka, and she also is a social worker. She runs the NGO for poor women and children, and has adopted NR Colony BBMP Hospital under Radhakrishna Foundation to render infertility services to the unreached. Apart from all this, she always invites me to have food at her home, and very, very, very yummy food she gives. And there are so many good things about her. I think it may not be possible for me to complete here. So welcome, dear Vidya. You don't have to do namaste for me.
Thank you to you. A big thank you to you, because you made my CV so beautiful as you are.
Thank you so much. Okay, now I have another very interesting person to invite here. That is Dr. Ashish Kale. The way he smiles is so naughty, now also he's smiling. So he's also a very dear friend of mine, and I have always told him that you have a very bright future, Ashish. And so he's doing too well, especially in IVF and endoscopy. And he is the director of Asha Hospitals. What a lovely name you have for your hospital. And Asha IVF Center, Pune, director of Arunachal IVF Center. I read about this. You produced the first baby of that Arunachal Pradesh. Congratulations for that. And so many other, organizations he's with, and doing a lot of work for ISAR as well. And also he's associated with the Maharashtra ISAR. He's an executive member, and Champions of ISAR Award in 2020. Executive Vice President, Pune OBGY Society, Treasurer of Maharashtra Chapter ISAR. He's a peer reviewer of Suffolk Journal, recipient of Kamini Rao Oration, FOGSI Future Award, Young Achiever Award Pune, Young Researcher Award POGS. I can see you as the future president of ISAR as well as FOGSI, Ashish. So,
thank you, ma'am, for this introduction. Really, you make my day.
All of you also have made my day by, Ramani has given me this chance to introduce such nice friends. So you can go ahead with the video presentations.
Yeah, thank you so much, Kanthi ma'am. You have always very nice words to tell about everyone, because that shows the real greatness of you. And it is a great honor to receive from you those kind words. So to start off with this interesting session, I would like to invite and welcome our first judge for the day, Dr. Krishna Kumar. Who else can judge better than the president of IAGE? So, sir is a renowned endoscopic surgeon. He has great skill in hysteroscopic surgeries. His hysteroscopic Asherman surgeries are like a real art. So he's also the treasurer of...
this is the old series.
Old series, yes. So he's not, yeah. Yes, so, okay. So over to sir for this judging this session. And I would like to hand over to Dr. Vidya Bhatt to introduce and welcome the next judge.
I think we should add to Krishna Kumar sir, because he is now the president of IAG and one of the best presidents who has coordinated so well the programs and who has conducted all the meetings so beautifully. And recently he conducted a conference which was so overwhelming and everybody appreciated that conference, and we look forward for a great year from you, sir.
Thank you.
Talking about Dr. Pratik Tambe, a very nice gentleman, and I know him for many years. I think first thing I'll tell is talent. He's a very good photographer. And then, of course, all this comes, he is an ART consultant and an endoscopic surgeon. He has done his diploma from France, advanced endoscopic surgeries, and he's been trained in ART, and he's also trained in embryology. I mean, it's a rare combo of all three, and I'm sure you'll be getting excellent results if a patient goes for IVF with him. And then he has been the chairperson of Endocrinology Committee, EMOGS, and also FOGSI, and then governing council member IAG, executive committee member ISAR, and then managing council member IAG. And he has been the recipient of many awards and prizes. You can see the list of that Mayor Hansotia Award, DC Datta Award, and then FOGSI 3 Champion Award, Durusha Award, and R.D. Pandit Award. And he has written many books. I mean, at this young age, writing so many books and involving in so many academics is great. Over to you, Ashish, for introducing the next judge.
Thank you, Dr. Vidya. It's been an honor. I'm introducing the next judge. And I'm really, at the outset, I'm thankful to Kanthi madam, Ramani madam, and Asha madam for giving me this opportunity. The next judge is a Jaydeep Tank. He is a good friend of ours as far as the FOGSI is considered. He is a consultant at Ashwini Hospital, a Center for Assisted Reproduction and Endoscopy. He is an honorary professor at Pacific Medical College, Udaipur. He is a recipient of Kamini Rao Orator and Bhaskar Rao Gold Medal in his DNB. He has many publications in journals. He is also editorial board of index journals. And apart from this, I think he is the good judge for this session because he is involved in both as far as endoscopy and ART is considered. Over to, I think the session will be conducted.
Yeah, so we have 4 video presentations for today's prize. The first would be by Dr. Damodar Rao. He would be presenting on TLH for dye. So may I request Dr. Damodar Rao to share his presentation and go ahead with his talk?
Yes, ma'am. Yeah. Seen? Hello?
Yes.
Yes. Your screen is.
Yeah. So my topic and video for today is TLH for in grade 4 endometriosis or in DIE. The steps would be same for if it is a conservative surgery, there is a so sure resection technique. So I just modified it a bit and made it so upper bap. So the steps are similar. You have the survey of and mobilization of sigmoid, ovarian mobilization, ureterolysis, pararectal space entry, rectovaginal space entry, bladder mobilization, adnexal mobilization and removal, and finally the uterus removal and pelvic peritoneum excision, if at all. So this is a mnemonic that is stands to do TLH in case of DIE or total laparoscopic hysterectomy. Let's directly go on to the video without wasting any time. So most of them might have congenital adhesions, or you might even have bad pathological adhesions like this. Here you can see that it is attached even up to the round ligament and the fundus. So what you have to do, the first step is the sigmoid mobilization. Once you do the sigmoid mobilization, a lot of things will become clear to you. So after doing the sigmoid mobilization, here you can see that the pararectal fat is attached to the uterus. It's usually the pararectal fat that is attached. And in very bad cases, you will also have the sigmoid that is completely pulled, the rectum that is completely pulled up. And so this is separation of the congenital adhesions first. Once that is done and you enter the pararectal space, the first thing, the first structure to identify should be your ureter. Once you identify the ureter, everything else falls into place. So if you go little medial to the ureter, the space between the ureter and the rectum is the medial pararectal space, or the space of Okabayashi. This is very important because below, in this space, below the level of the ureter, you will have the nerves S234, and you should be careful not to damage this. Next would be to enter in the space that is behind the rectum, like how in bladder we dissected from lateral to medial. Similarly, rectum also can be, the space can be entered from lateral to medial, and you can get a good plane. Next, we open up structures on the right side, and you don't have to follow this particular mnemonic. Wherever you have some space, you can open it up. Here you can see on the right side, we're trying to open up the space between the ovary and the IP ligament, and we're trying to free it up. Again, the main important thing is once you've identified the ureter on the left side, you should also identify the ureter on the right side. Here, I am approaching the ureter from the medial side, right below the IP ligament. That's one of the landmarks. Below the IP ligament, you'll usually see the ureter. And in this case, it was interesting that we saw a double ureter on this right side. And first, I wasn't very sure. And on further dissection, it became very clear that this is actually a double ureter on the right side. And you can see how closely applied to the rectum it is. So ureterolysis on both the sides is very, very important in any case of grade 4 or deep infiltrative endometriosis. Once it is done, then your surgery becomes a lot more easier. So this is a little more dissection being done just to make sure that the structure is actually the ureter. It was quite thick initially, I thought, just to be a single ureter. And then on further dissection, I could actually make out that these are two ureters, that the peristalsis of both the ureters is seen clearly. So once both the ureters are identified and then you enter the pararectal space on both the sides, you have to open up all the avascular spaces. Basically, here I'm on the left side, this is the uterine artery at the origin. If it's difficult to find, you can trace it down from the obliterated umbilical and come down. And here you can see the space, the left paravesical space and the left pararectal space divided by the uterine artery. Once the posterior structures are done, then you go anteriorly to the bladder. That is what I usually follow. Once the posterior structures are done, then you go anteriorly to the bladder. And of course, bladder dissection, I think we are all well versed with. Again, you got to stick to the dictum that fat belongs to the bladder. And with this in mind, if you continue your dissection, your bladder will be easily pushed down without any problem. So this is again the left uterine artery being identified. And coming back posteriorly, after doing all this, you have to, what I generally do is removal of the adnexa, that is removal of the tube and ovary. Once the tube on the uterus easily, here you can see how closely the ureter is applied below the ovary, and hence I shifted to cold scissors. And once the adnexa is removed, you get easy access to the uterine artery. And I prefer to open up the vault on one side anteriorly, go posteriorly, and then again further posteriorly from one uterosacral ligament to the other uterosacral ligament. I prefer to open up the vault completely on one side so that when you approach the uterine artery on the right side, you know where your points are, and all you have to do is just join the dots. Cutting the IP ligament on the right side will also allow you to free up the ovary on the right side and the tube on the right side. And once the right adnexa is also released, then you'll again have access to your uterine artery, and we almost reach the end of the procedure. And that's your uterus being separated. And we always check for bowel integrity at the end of the procedure. There was a small serosal rent that happened in this particular procedure, and I just placed a figure of 8 suture with 3O Vicryl. And then following this, the vault was sutured. In the usual way, I place 2 figure of 8 interrupted sutures at the angles and prefer to leave the center a little open so that there is a drainage of fluid. And I always follow it up with a cystoscopy at the end of the procedure, just to make, I don't know, maybe sleep better at night. It really doesn't mean much, but maybe just will tell you that you have not transected the ureters. That's about it. But I just prefer to do a cystoscopy at the end of the procedure. So that is my technique for total laparoscopic hysterectomy in grade 4 or deep infiltrative endometriosis. Thank you.
That was very nice, Dr. Damodar. And can I ask 2 questions? Yeah, you can hear me, I suppose?
Yes, sir. Yes, sir.
In this case, of course, you have demonstrated very nicely how you took care of the ureter. But apart from the lateral pelvic wall, where else you think this ureter could be damaged, and any other steps you think can be done to prevent or avoid ureteric injury?
Apart from the lateral pelvic wall, maybe anteriorly also, where you push on the bladder, that is one area where you have to be careful below the level of the uterine artery. If you go a little lower down, below the knuckle of the uterine artery, then you will again come across the ureter over there. You should be careful and be careful while dealing with the uterine artery over there.
So what precaution you will take at that point? Because that is one of the most common point where we dissect the ureter at every place, but near the vault, I have seen the injuries occurring more even when you have dissected the whole trace the ureter right from the brim.
Yeah, one thing what I do is I generally insert a CC ball so I know where the vault is high enough. The highest point of the vault I get to know. That's one technique I follow. Another thing we can do is also enter the vault medial to the uterosacrals. If you enter the vault in that area also, then you will be able to get the cervix. And then once you pull the cervix up, if you stay flush to the cervix, usually you will not injure it. One more point would be try and stay above the knuckle of the uterine artery. Don't go and dissect below the level of uterine artery, and don't coagulate below that level. That's also one of the points which will safeguard your ureter.
Thank you.
Thank you, sir.
So do you have any other questions, sir? Dr. Pratik Tambe, sir?
No, that was a lovely video. Thank you,
Yeah.
Thank you.
Okay.
Thank you,
for
sir.
sharing that with us. I think we'll move to the next speaker.
On time. So we like to invite the next speaker, Dr. Preeti Goswami. So she is going to present her video now on the techniques of endometriotic cystectomy. Dr. Preeti, you're there?
Hi, yes, ma'am. I'm trying to share my screen. Good evening, everyone. I'm Dr. Preeti. I'm going to tell about the various techniques of the endometrial cystectomy. Endometriosis is a chronic multifactorial disease which always remains elusive and enigmatic. So the treatment option should be individualized based on the patient's need and preference. So let us review the various techniques of the endometriotic cystectomy and its technical aspects. Usually, the endometrial cyst is mobilized from the ovarian surface and the pelvic side wall. Actually, once we are mobilizing from the pelvic side wall, there is always a weakest point that is usually called as an punctum of the endometrial cyst, which usually gives away, and the chocolate-colored fluid is usually drained out. And once the fluid is drained out, then we will follow the techniques of the cystectomy, like we will tent and cut, traction, counter traction, like those things we will do. And there should be a proper cleavage plane in order to delineate between the ovarian tissue and the endometrial cyst, so that we will try to prevent the injury on the ovarian hilum, because the ovarian hilum is the one which contains the highest number of the ovarian follicles. And she is a 27-year-old primary subfertility patients, married for 2 years. She came to us. She has.
Sorry to interrupt you. Please make it a slideshow.
Okay, ma'am.
Yeah.
She is a 27-year-old primary subfertility patient, married for 2 years, and she has ovulation induction done elsewhere twice. And she came to us. She had an bilateral endometriotic cyst with a large cyst on the right side. So we have planned her for laparoscopic endometrial cystectomy, and along with the bilateral tubal evaluation. And here we just freed it from the pelvic side wall. Once we are as we are freeing from the pelvic side wall, actually before that, the endometrial cyst will have the 3 zones. That is the zone A, where there is the cyst wall invagination will be there, and it is the weakest point. And from the weakest point, usually it is called as a punctum, it will give away, and the chocolate colored fluid usually used to get drained out. And the second is the zone B, which will be around the zone A. And if for the cystectomy procedure, it will be better if you are able to have a better cleavage plane. And next is the zone C. And zone C is the ovarian hilum. We should try to avoid injury to the zone C. And in this endometrial cystectomy, we just mobilize the endometrial cyst from the pelvic side wall. And as we are mobilized, the endometrial cyst gets spontaneously ruptured on its own, on its punctum, that is zone A. And once that all the chocolate colored fluid is drained out, we are enlarging the incision, and we try to do the cystectomy from the periphery to the center. It is one of the techniques which will be done usually, because from the periphery to the center, it will be easier for us to do the cystectomy. And in this case, we will try to avoid injury to the ovarian hilum. And as the ovarian hilum is reached, we will try to avoid injury to the ovarian hilum, and then the endometrial cystectomy is done. In our hospital, we will try to use the harmonic scalpel, so that the vascular injury will be less. And another technique, if the cyst does not rupture during mobilization, then we can make an incision on the endometrial cyst, and the fluid can be drained out. and the endometrial cystectomy can be done in the usual way. And another approach, in case of a large endometriotic cyst, we can just do the endometrial cyst mobilization and fluid drainage can be done in the usual manner. But once the fluid is drained out, then we can avert the cyst and make a nick at the center of the cyst so as to create a wedge between the cyst wall and the underlying stroma. Then the cyst excision is usually done in the same way. Many times in case of a large endometrial cyst, the cyst wall is less adherent at this place and we will tend to get a good plane. This is a 28-year-old female. She's married for 3 years and she tried spontaneously and she came to us and she had a large endometrial cyst of around 8 centimeter size, and we planned her for bilateral tubal evaluation laparoscopic endometrial cystectomy, and the endometrial cyst was mobilized from the pelvic side wall and the chocolate colored fluid was drained out in the usual manner. And once the fluid is endometrial chocolate colored fluid is drained out, then we will try to avert the center of the cyst. And in this patient, we injected the vasopressin so that we will get a better cleavage. And once after injecting the vasopressin, we made a nick on the center of the cyst, and then we create a cleavage plane. So that the dissection was better. And while we are doing, we always try to catch hold of the endometrial cyst with the tooth instruments and the other ovarian tissue with the non-tooth instruments, so that the damage to the ovarian follicles and ovarian tissue will be less. So in this case, ovarian tissue was holded with the non-tooth and the endometrial cyst was held with the tooth, and with the usual traction and counter traction technique, the ovarian cystectomy was done from the center to the periphery. This will be very useful in case of a large endometrial cyst. So the hemostatic measures which we are using in our institution is vasopressin plus cystectomy. We usually used to inject the vasopressin once the cystectomy is done for a better cleavage in order to reduce the amount of bleeding. And in some case, in case of a severe adhesion, we tend to inject vasopressin into the fundus of the uterus also, so that there will be a better hemostasis and reduced amount of bleeding. And the second is the usual electrocoagulation technique. We generally prefer to use this water test. That is, we will irrigate with a lot of normal saline. Then we will try to identify the bleeder points and we'll give the target application of the bipolar. We will coagulation. We used to coagulate the target application. Suturing, we generally won't suture the cyst wall because it will increase the postoperative adhesion formation. So we will tend to suture only if there is excess bleeding. As far as we have seen, I have seen that we generally don't suture the cyst wall. Thank you.
Dr. Preeti, nice videos. I have just a couple of small points
Yes, sir.
that I would like clarified. Number one, any special bowel preparation you use prior to the surgery?
Sir, we usually used to use that XLA protocol a day prior to the surgery in order to prevent the bowel injury, or we used to give a light meal on a day prior to the surgery and soap and water enema. But for endometrial surgery, we will try to use an XLA protocol so that the bowel preparation is better and so that the bowel damage can be prevented. Sir.
Good, excellent. And second point is, when you use the harmonic case, do you find there's a lot of smoke which clouds your vision?
Sir, it can happen, but we usually used to use the suction device also to evacuate that
Correct.
smoke.
So that's why your turnover of CO2 must be quite high when you're using suction as well as harmonic case at the same time. But
yes, sir. But,
nice videos. Thank you so much for sharing with us.
Thank you, sir.
Krishna Kumar sir, do you have anything to ask Dr. Preeti?
No, I would just recommend or maybe make a comment whether when bilateral endometrioma is seen, what additional precaution you would take preoperatively, or would you like to give her something before subjecting her to surgery, because the reduction of ovarian reserve would be more if you were to do cystectomy on both the side? Or what is the
Sir,
criteria for doing cystectomy
sir,
on endometrioma?
Sir, preoperative, yeah, we have done the preoperative AMH for her, sir. It was 3.62. So we plan to do the laparoscopic cystectomy since she is an primary infertility and married for only 2 years, sir. So that and she has severe dysmenorrhea also. So that there will be the recurrence of the pain symptom also will be decreased. So we plan for cystectomy. But we explain to the patient that only the cyst aspiration can be done, then we can go ahead so that there will be less reduction in the ovarian reserve, but the recurrence rate will be higher. So we explained preoperatively. The patient opted for the laparoscopic endometrial cystectomy.
No, bilateral endometrioma, maybe one side one can do the cystectomy, and the other side one should try and do just coagulation, not just cyst aspiration. Cyst aspiration per se will not really help you much at all because the recurrence rate will be very high. So you can do selective coagulation at those endometriotic spots if there are bilateral endometrioma. That is what the current teaching goes to relieve dysmenorrhea. Thank you. Nice presentation.
Thank you, sir. Thank you, sir.
Yeah, thank you, Dr. Preeti. You finished on time. So I'd like to invite the next presenter, Dr. Impashri. Dr. Impashri, you're there?
Yes, ma'am. Yes, ma'am.
Please start your presentation.
Good evening, everyone. I'll be presenting a video on management of frozen pelvis in case of endometriosis. This was a case of 35-year-old female married for 6 years with primary infertility. She had had 2 failed embryo transfers before and had presented to us with severe pain, dysmenorrhea, as well as chronic pelvic pain, which was present throughout and on when she was taken up for laparoscopy, the intra-op findings were she had a totally frozen pelvis with full bowel adhesions to the posterior wall of the uterus. The bowel adhesions were released using scissors. The endometriotic spots were coagulated. Because she had already had a OPU and had frozen embryos, the plan for her was for a embryo transfer post clearance. To prevent the further adhesions, an interseed was placed. 3 months post-operatively, a frozen embryo transfer was done. This was another case of 39-year-old female who had para 2 living 2 with 1 previous LSCS. She had presented to us with symptoms of dysmenorrhea. TVS showed a large ovarian cyst on right side, which was about 5 into 8 centimeters. Intraoperatively, the bowel, there was the frozen pelvis with severe bowel adhesions. Because the plane reaching the plane was difficult, a lateral approach, retroperitoneal approach was followed. Once the peritoneum was dissected, the bowel adhesions were released. The sigmoid colon just falls back. Then the right-sided ovarian cyst was removed. Cystectomy was done, and the cyst was removed using an endo bag. The endometriotic spots were coagulated. The cyst was removed using an endo bag. She was followed up with medical treatment. A third case, she was a case of primary infertility. 32-year-old female had presented with chronic pelvic pain. She had she was being operated before for endometriotic cyst outside almost around 3 years ago by abdominal approach. Now she had presented to us with for the management for infertility as well as severe dysmenorrhea. Intraoperatively, there were severe bowel adhesions with frozen pelvis. The bowel adhesions were released using cold scissors. The AMH levels done prior to surgery was 2.6. During the due to severe adhesions, during the release of bowel adhesions, a small serosal injury was noted, which was sutured using 3-0 Vicryl. It is always better to avoid energy source and go for suturing in case of bowel. Thank you. Thank you. I would like to thank seniors for giving me this opportunity to present.
So over to the judges, please.
Yeah, in the case shown, Impeshri, you said this patient was operated for the second time and she was also for infertility. So before taking her for surgery, was the option given to her to go for stimulation and oocyte retrieval, or only surgical option was given?
No, sir. Option was given to her, but she had such severe pain that she didn't want to continue with her infertility treatment. She had already decided for adoption. Though we counseled her, she was not ready for it, sir.
If she would have been ready, what you could have offered to her?
Sir,
And what you could have
ovarian,
done at the same time for a pain?
Ovarian stimulation and then pickup, followed by endometriosis clearance, and then transfer would have been an option if she were to be ready, sir.
Yeah, that should be the message. Thank you.
Thank you.
So just one query. Did you do anything specific, rather any specific investigations to rule out stage 3 endometriosis? Because this is a patient with chronic pelvic pain. So any special investigations before you took her up for surgery?
Sir, MRI was done, sir.
All right.
There was no deep, like features of deep and infiltrating endometriosis as such. Yeah.
So there was no rectovaginal nodule that you could identify?
No, sir. Even either on TVS or
Okay.
vaginal
Okay, great. Thank you so much.
Thank you.
Thanks a lot. Lovely video. Thank you so much for sharing with us.
Yes. Can we have the next presenter, Akshalata, to share her screen?
Yes, sir.
Is she there? Yeah. Thank you.
Good evening, everybody. I thank all of you to giving me an opportunity to present the video. Today, I will be presenting on ovarian reconstruction. Am I visible?
Your screen is not.
visible. Yeah, share
Yeah.
the screen, please. Yes.
You can share the screen, actually.
Yes, sir. Yes. I'll be presenting the first. I'll be presenting the first case was a case of an adolescent girl who presented to us with severe pain abdomen and dysmenorrhea. On ultrasound, a large endometriotic cyst was noted, and after a workup, she was posted for surgery. On the basic surgical steps were putting up a 10 mm port and 3 conventional 5 mm ports. On we directly suction the cyst to drain out all the endometriotic fluid to avoid the spillage. There was adhesions between the posterior uterine wall and the bowel. An incision was given at the ovary, and the cyst wall was separated from the ovarian parenchyma with attraction and countertraction. And after the cyst wall has been removed, we did an ovarian reconstruction with suturing. The main thing was to prevent to achieve hemostasis. And to avoid the use of cartridge to preserve the ovarian reserve. This was a case of a 30-year-old female who presented to us with infertility and with dysmenorrhea. And on scan, there was bilateral endometriotic cyst noted. Similarly, in this case, we aspirated the cyst, endometriotic cyst with chocolate-colored fluid was drained. And after that, we did a cyst excision, and the part of the endometriotic tissue was also removed. We use harmonic here to avoid damage to the ovarian tissue. We need to aspirate out all the endometriotic fluid present there to avoid recurrence and spillage.
In case of a large endometrioma, suturing is required. But in cases of small endometriomas, we try to avoid suturing because suture material can cause further adhesions. And the endometriotic cyst removed was retrieved through an endobag. This is another case where the patient presented to us with infertility and persistent pain, who had undergone multiple infertility treatment and failed medical management for endometriosis. So we had to take her up for the surgery. Incision was given at the cyst wall and all the endometriotic fluid was removed. And ovarian reconstruction also was done in this case. The adhesions was released. Nick is usually given on the thinnest part of the ovarian cyst or at the antimesenteric border of the ovary. Endosuturing was done to achieve hemostasis. And the endometriotic spots were cauterized using a bipolar cautery. There was a small rent noted on the ovarian tissue. So to avoid energy sources, we had to do suturing. Thank you.
I sincerely thank all the presenters for their presentation. Maybe move on to questions. Krishna Kumar sir, Dr. Pratik, and
Yeah, as far as reconstruction, suturing, yes, of course, you thought of doing just for preventing the hemostasis, but you could see that at the end of the surgeries, the ovaries were going back to the original position behind the pouch of Douglas. And what else you could have done to prevent that adhesion from forming? Because that's a big problem with such endometriotic surgery, where you do everything on table, but after 48 hours, you'll find them they're back to their square one and the same complaint may recur. So what additional precaution you could have done to prevent that particular problem from recurring?
We could have used an interseed to prevent adhesions. Pelvic wash can be given, and put them on medical management, sir, after this.
Okay, have you heard about temporary ovarian suspension? What is that?
We plicated to the round ligament.
No, plicating round ligament will be permanent. You know, the epithelialization is supposed
bring it out through the ports in the lower RIF and LIF.
Epithelialization is
for a
supposed
short
to
period of
start and complete by 5 to 7 days. So the ovary is suspended to the anterior abdominal wall by placing sutures through the abdominal wall, and then you can cut the sutures from outside, and then the ovary is supposed to fall back. So that is one commonly recommended method with some good results, where you can prevent, adhesions, where the adhesions are more common in the first 48 or 72 hours when there's hemorrhage, raw surface. So that is one step worth doing in such cases.
Okay.
Thank you. Anything, Pratik? You can.
No, sir, it's always instructive to be there with you because we always learn so much. Thank you so much for being with us today. It's always wonderful to have you with us. And of course, I must express my gratitude to Dr. Ramani Devi and the coordinators for this particular session, Dr. Mala Raj Vidya Bhatt and Dr. Ashish Kale, for doing such a wonderful job. And thanks to all the presenters for sharing their videos with us.
Thanks for calling us as the judge. Thank you.
Yeah, thank you so much, Krishna Kumar sir and Pratik Tambe sir, for your valuable time and spending your knowledge and also giving us your inputs. So we would like to get the result. Maybe you can just share it with us, and then we'll hand it over to Ramani madam. So thank you so much, participants, and thank you so much, judges. And thank you so much, Ramani madam, for giving us the opportunity to coordinate this particular session.
So on behalf of the organizers of Endometcon-3, I'm very grateful to Professor Krishna Kumar, Pratik Tambe, Ashish Kale, Damodar Rao, and all the other persons who have presented, and Vidya, but everybody, Mala Raj, who has been coordinating this so long, for the wonderful, for those who have presented. It was every video was very nice, and I thank the judges for having spared the time, and the organizing team also for having spared the time to coordinate everything and take it in a smooth way.
Thank you, madam. Thank you for inviting us. Thank you,
So
doctor.
just Vidya, if we can get it in few minutes, I think we can announce the results.
Yes.
Is this video, because for the paper and poster only one person has sent the result. If they are going to send it within few minutes, I can tell the results. Otherwise, we'll declare it in the.
I can send in 5 minutes. I'll send it in.
Okay.
Yeah. Yes, sir. Yes, sir.
Thank you, madam.
The video session was really very good. It was a feast to the eyes.
Yes.
Madam, if we could start giving out the results of one by one, or we wait for the video results also. We have.
Dr. Vidya Bhatt, ma'am, I've shared with you. If you want a more formal with breakup.
Yeah.
On WhatsApp, is it?
Yes.
No, it's right here in the chat.
It's in the chat.
Yeah. No, you have to give everybody's result markings.
This time it was a very fair way of marking the numbers. So we judges were also kept in dark. I didn't know what the other two are really marking.
Yeah.
So it was very fair.
Ma'am, Ramani ma'am, I would just like to share my thoughts. Actually, when you started this conference and when you were saying about so many competitions, I was really wondering how this will go on. But ma'am, it has gone so smoothly and so beautifully. The quiz, the essay competition, the paper presentations, and the video sessions. Even in a conference, maybe where we all get together, there'll be so many confusions. That person is not there, this person is not there. But now I think it has gone off really well. And I must congratulate you, Asha madam, and Kanthi madam. You've been putting so much of efforts. Of course, we are like, we are not available at times. We say, ma'am, we'll join the meeting later. But you people were so persistent and consistent with your work. You have just brought out simply a wonderful session with all these really, encouraging competitions to youngsters. I think many have shown their talents. Congratulations to all the main organizing team. I wouldn't say the chotu ones, but the main people. You people have
all have put in their efforts. It was such a collective, friendly group of our team.
Can I announce the results of the?
Yeah.
Yeah, time and question answer.
That's
It's given by Pratik sir. So we have 2 winners in the video competition. Can I give out Kanthi madam, or do I have to wait?
I think Dr. Ramani is on phone.
I think you will need to make an average of both the judges because
Yeah.
Kumar sir was also there.
Kumar sir is saying? No. Krishna.
So first 2 prizes only out of the 4.
Okay,
So,
ma'am. I'm just waiting for Kumar sir's.
Yeah, I think the poster and paper is also getting ready. Maybe in another 5 minutes we'll be getting it. Not even 5 minutes. Because Murali has sent me the result.
Third one. Okay. The first was Damodar.
So, Vidya, what you are saying is so correct, but I would like to put in a word here that 95% was Ramani's work, and we all together have contributed 5%.
No, not at all, madam. It's
We have Chotus, no, only 1%, ma'am.
No,
you 99%.
No, but this is a very good method of doing, you know. If
Yes,
there are
yes.
too many people poking their nose, then the conferences are never very
And
successful.
very smoothly, ma'am, very smoothly, the judges came and they gave their decisions, questions. Everything was so smooth and beautiful. I mean,
And also there was no technical snack from anybody. I think I only had a little, one or two of us had little internet connections in between problem, but otherwise no.
I mean, really great, ma'am. I'm so overwhelmed with these, with this, especially this pre-congress session. Very nice.
Actually, today I sent to many groups, and so many have written thank you. It is so nice.
So even the people who have logged in from morning, they were saying that there's so much of information. Even that yellow ribbon understanding. I think you have brought this conference and taken people's knowledge to a different level, because now many have understood the importance of endometriosis and the logo, and then what is FOGSI Endometriosis Committee. Everything people have understood. Probably in a regular conference, this wouldn't have been so clear.
Correct. And the quiz committee also, they have done a very good job. In fact, I liked all the questions. They were in depth.
Yes.
And also at the same time, simple questions. Like yellow ribbon and blue ribbon, they were not able to make it out.
Yeah.
And that month of endometriosis.
So Pratik has sent me the results. Then what about Dr.
Madam, Krishna Kumar sir has sent, ma'am.
You forward it to me.
Yeah.
You forward it to me. And the other one is Dr. Pratik Tambe, Krishna Kumar sir. Then one more person.
2 judges were there, ma'am, today.
Only 2, ma'am. Dr. Parikshit didn't come, I think.
Okay. So you send me Krishna Kumar's.
Yeah.
Ma'am sent, ma'am. I have sent one. I think Mala, you have Krishna Kumar sir's, no?
Yeah, I'm sending that.
Yeah.
Because Pratik has sent it to me directly. Mala send it to my WhatsApp.
Madam, I'm sending her.
Such a focused conference.
Yes.
It is getting so much of popularity.
Ma'am, I sent, ma'am.
Yeah.
I think, ma'am, you only give out the results.
Yeah,
And
you
then-
send it to. Second is Dr. Damodar, and second is that 5th candidate.
Akshata.
No. See, Shri. What is her number? What is her number?
He was a third speaker.
Third.
Yeah.
Third is Impashri, I think.
Yeah.
So then, Parikshit had Pratik Tambe has given for Damodar first mark.
Yeah, Krishna Kumar sir also Damodar first, ma'am.
Okay.
And,
Then the second mark by Dr. Pratik Tambe is number 5.
Number 5.
What is the mark exactly, so that we can calculate? Out of 10, how much he has given?
Yeah, that I will check, ma'am.
Yeah, only if you tell that I can put the average.
Ma'am, I have sent to you. Marks. Yeah.
Yeah. Yeah, that's fine. So this is whose valuation? Vidya, you have sent one, no? Whose valuation?
Yeah, that is Dr. Pratik's valuation.
Yeah, I got this. Now I want Krishna Kumar sir's valuation.
If you could kindly send me, Krishna Kumar sir, if you could kindly send me your
The number of marks, sir, out of 10.
Where, how many? 4. No?
I'll just now send. I'll send it to Vidya just now.
Yes, sir. Please.
Okay, okay. Vidya, transfer it to me.
Yeah.
Dr. Ramani, I think we don't generally have essays in the competitions, but this was really nice.
Because I thought, see, now we know how to put the effort by the students, and the pattern of writing, it will be a sort of encourage them for writing future papers. So that I thought of making that essay.
And the other benefit for the judges was generally in the other live conferences, they have to get up early in the morning or afternoon during lunch and
Ma'am, travel. We are not talking about the efforts you put in the travel. You take a
No,
early morning
I'm
flight.
just telling all the judges also agreed to be a judge because of that point, you know.
Yeah.
It was convenient time also.
I didn't get Krishna Kumar sir's.
I'm just waiting for Krishna Kumar sir.
Yeah.
And you can hop in from conference to conference. I'm already in another meeting being done by MC Patel.
Sir has put marks for only 4. There were 5, no?
No, only 4.
4, no?
Yeah.
Okay.
Only 4.
Only
4. Okay.
So number 1 is Damodar gets the first highest in this.
Yeah. Sir sent, ma'am. I forwarded to you.
Okay. I'll just see. No, but Pratik has given marks for 5.
Ma'am, I think third one he has repeated. Third one he has repeated twice. It is 1, 2, 3, 4. So the fifth is 4th. Yeah, the 5th is the 4th one.
Okay. Then I will just tell you the marks now.
Yes.
So 16 for number 1, number 2 gets 11, number 3 gets 12, and number 4 gets 12. So number 1 is Damodar. Okay, he gets the first mark. Then second prize is shared by 2 people.
Okay.
Third and 4. Who are the third and 4?
Third and 4. Yeah. Third is third and 4. Okay. Impashri and Akshalata.
Okay.
Oh, only one has not got. What is? Give her also.
Consolation prize, ma'am.
Okay, but even her was okay. So you just write, send me the third one is second one is Impashri, third one is what is
Second and third same, you said, no, ma, same scoring.
Third name of the third person. Name of the third person. Akshata
and Impashri stand second, ma'am.
Yeah.
Third is Preeti.
Preeti, yeah.
So congratulations to all the winners.
Congratulations.
As you can write.
Rising star from South.
Yes. My students, ma'am, I'm so proud.
All of us are proud because I think basically even Krishna Kumar is from South. Ashish, go to your clinic.
Romba santosham.
Congratulations.
Tumba santosham.
Tumba santosha.
Tumba santosham.
Nandri, sir. Nandri.
Asha, congrats.
Thank you.
Proud mother of a bright
son. Asha, ma'am.
Thank you, Mother. Thanks to all his
Thank you, sir.
Yeah, 1 minute. He has sent a mark.
and everybody.
Priyankur, where is Priyankur?
Priyankur is another meeting. Amniotic fluid. He and me are in the another meeting.
And we got to announce the results of the other 2 things, that poster and paper.
Can you call him and ask? Dr. Deepika,
Okay, madam, I will take leave, ma'am. I'm going
Nice to see you.
Thank you.
You have lost a lot of weight.
Oh, is it?
So Vidya, you are supposed to give the vote of thanks.
Ma'am, I'm waiting. If you permit me, I'll start.
Yeah.
Okay.
Poster and paper also we are announcing now.
Yeah.
It's a proud moment to give away the vote of thanks because as I was saying, I did not expect this conference to start off so well, and everything which has started off well with, I mean, half the job is done, and I'm sure tomorrow and day after tomorrow we are going to have wonderful sessions from all the international faculty. But today's was very interesting, and the efforts put by the generation next, the youngsters, is really immense. It's nice to know that so many people are doing such good work in something called this enigmatic disease, endometriosis, wherein every person and even surgeons, I think, get scared to put in a scope whenever they find that there is endometriosis. I would really like to thank everybody who has put in all these efforts from the bottom of my heart, because I know how much of efforts have been put for the past 1 month, and all the backend team, like the coordinators. I would like to first thank all the coordinators. For quiz, it is Sebanti Goswami, TV Chitra and Chitra Ramesh. For essay competition, Dr. Neharika, Dr. Venugopal and Dr. Oby Nagar. And for free paper and poster, Asha Rao Madam, Subash, Mallya and Priyankur Roy. And I would also like to thank the judges. Judges for the quiz, essay, Dr. Das Mahapatra, Dr. Pradip Mishra and Dr. Kanthi Bansal. For the free paper and poster, Dr. Muralidhar Pai, Dr. Vidya Tobi and Dr. Neelam Mishra. And for the videos, Dr. Krishna Kumar and Dr. Pratik Tambe. Then, of course, our backend team, Rajesh and Jackson and Paul Pharmaceuticals, and the whole organizing team, the organizing chairperson, Ramani Madam, Kanthi Madam, the scientific chair, the two great organizing secretaries, Asha Ma'am and Dr. Kundan. And then, of course, all the coordinators whom I have thanked, and even the video coordinators, Mala and Ashish, have just put in a lot of efforts and done a wonderful job. And all the participants, you people were so good. May it be quiz, may it be the essay competition, the paper, and such wonderful work has been done with the paper presentations. I was just seeing how much of efforts has been put to sort of really tease and understand this enigmatic disease. And then, of course, video. Such skillful surgeons we have in our country, and that to the younger generation. So nicely each step was delineated. So I thank all the participants and everyone, and I think Abhinaya and who else? Somebody who, I can't get the name.
Abhinaya, Kalpana and Shilpa.
Abhinaya, Kalpana and Shilpa. They were constantly on WhatsApp giving us all the information, and I will definitely be failing in my duties if I don't thank them. They have done really a very good job, and I thank one and all. If I miss somebody, it is just like I haven't got their name, but everybody, congratulations to you, and thank you so much. Have a very nice feast of learning for the next 2 days, and thank you one and all. Thank you, Ramani Madam.
Now we have got the results for the paper and the poster. Paper first prize goes to Bishita Bakshi. Second prize goes to Abarajita. Third one goes to Geeta. But I think we are having only 2 prizes.
Ma'am, give one consolation, no?
Okay, please. Then the third poster.
And I will want one for essay also.
Yeah.
Why only 2 for essay?
Yes. Yeah.
Oh, essay we are giving 3, madam. Because there were a lot of, for the PGs, we are giving 3, and there were more number of entries. Okay, then for a poster, Geeta Raj gets the first prize. Second one, Suganya. Third one, Taraka Senti Raja. Senadi Raja. Taraka Senadi Raja. So I think everything is done. I'll put it in the group. So thank you. I once again, I should thank Dr. Deepika. So when I thought about arranging this program, see, actually, originally we thought of only 2 days. Then I said, something must be get into the minds of the youngsters. So then I thought about Dr. Deepika to arrange this program, and immediately she said she agreed. And even for the price amount, she has sponsored some amount for us. Great.
Actually, I have seen Jackson Paul from the very beginning. They have never refused a single time. Whenever we ask something, they will do it.
Correct.
Ma'am, it's all with your blessings.
Ramani for such a wonderful show today. I could call her a one-man industry. You know, she has done one-woman industry.
Yes.
So congratulations.
All women industry only today.
Women empowerment.
Including Abhinaya, Kalpana, and Shilpa.
And
Thank
see,
you all for
all
giving
tomorrow we are
prizes.
releasing the e-souvenir also, which will include the best essays, quiz questions, and if I get the abstract of the posters and this one, I can even put it across. Posters we can put it, but the abstract of the paper I might.
And thank you all for giving 3
and
prizes.
videos also. Videos also, we have the facility for loading the videos also in the e-souvenir. So it will cover the entire work.
Yes, yes.
And thank you all for giving 3 prizes to Coimbatore.
And 2 to Bangalore. Thank you. Bangalore.
Four to Coimbatore.
Great. Ma'am, Asha ma'am, your center only. You do so much of work.
No, I wish more had participated. That's all.
Yeah.
Maybe next time. Yeah.
And thanks to Bangalore. Thank you.
Okay.
Ma'am, on behalf of Jackson Pal, I would like to take this opportunity to thank everybody, especially Dr. Ramani Devi ma'am, for giving us this opportunity where we have been able to showcase our products also and interact with such great personalities, the faculty present with us today. On behalf of Jackson Pal, who are pioneers in Dynogest 2mg in tablet formulation as brand Endoreg for medical management of suspected as well as confirmed cases of endometriosis and endometriosis associated pelvic pain. Cyclorex CR10, that is norethistron 10 mg controlled release tablets with embedded polymer matrix technology that releases the drugs so as to attain plasma levels instantly and also to sustain the levels for 24 hours. And we have injection gonadoreg containing leuprolide acetate 3.75 mg. My teammates, Dr. Vipin Tyagi, Mr. Arvind Singh, and Mr. Amit Saxena join me, Dr. Deepika, to thank all the expert faculty present with us today. We would like to reassure all the experts our extended support to your future activities in the service of women's health. We hope to go a long way in knowledge sharing with the unending support of all the attendees present. We hope to see you in our next webinar tomorrow. And also the conference which is going on, Endometcon, for tomorrow and day after. Thank you very much.
Thank you, Deepika.